also online. And apologies. Any member aware of any apologies?
Yeah.
Okay, that'll be noted.
We might get it.
There's no an apology? Okay, fair enough. Okay, in terms of Chair's business, so just to advise everybody, myself and the clerk met with the Minister and the Permanent Secretary on Monday just to have an initial discussion in relation to the committee inquiry report on the palliative care. So the Minister requested that I pass on his thanks to the committee members for prioritising the important issue. So he obviously welcomed the direction the committee is suggesting, specifically with a focus on shifting left and reducing health inequality. So, I mean, given that it's just in draft form, we indicated that it's just in draft form and there may be some slight changes, and that we're now going to change the date of it. So that was that. The other thing then I just want to bring up in relation to the debate the other day on CAR-T therapy. So everybody here contributed to it, and the Minister, you'll be aware that the Minister, kind of in response to me, but others, I'm not saying issued a challenge, but issued that the committee could check the veracity of some of the comments that he was making. So I think that we should do that. I think that we should write. There was two issues. So there's the issue of the services being applied here in the north. So we should write to the department and ask them in detail why it's going to take so long, and also I know from some of your contributions there's an issue of clinicians who are saying that it can be done much quicker. I think that we need to interrogate that as well, and then separate to that, the issue of the making this an island-wide service in advance of it being available here in the north. I think we should write to the health service in the south just to ask about their capacity issue, and if they're opening the service in Galway, will that free up capacity, and what kind of work would be needed in terms of facilitating patients from the north. So if people are content, I think we could do that.
Can I just add, could we ask as well for an understanding, if we send somebody over to a trust in England, do we have to pay out of our health service for them to get that treatment over in England? Because if that was the case, and we've sent 70 people over the last few years, if we were to amass that 70 people's worth of costs, it could be something that we could give to the department in Dublin and say, could you extend the service that you have there? That might be able, because then Dublin might say we don't have capacity, but if we paid them and had an arrangement, they might be able to get more staff and then deliver it.
Absolutely. No, that makes sense. I mean, if we can just find out exactly what the capacity issue is in the south. Is it workforce? Is it space available? Is it something else? I think that would be good. Okay, so just advise members, we're going to have a further discussion, I should have said this earlier, on the report on the palliative care next week. Draft minutes, can I refer members to draft minutes of the meeting held on 18th of September, it's page 5, members content?
Yes.
Okay, so in terms of matters arising, so at their tabled paper pack today, people will see there's a letter from Mr. Roberts, page 199, he's father of Claire Roberts. So it's in relation to the discussion that we had last week. In last week's discussion, there was a bit of engagement with in relation to engagement with families, in particular, some of those, in this case, the hypernatremia families. So, I mean, obviously, the letter that we've got today from Alan Roberts is at odds with what we had got last week. So I'm just wondering if members have any comments.
The simple solution, Chair, is to support the private members, Paul Free.
Well, I mean, in terms of the letter, I think it's specifically about engagement on this issue. So, I mean, in terms of comment that I would have, I think we should go back and ask specific questions about, when they said there was really good engagement, who was it with? Because it obviously wasn't with key families that we would have assumed were included in the engagement. So obviously Mr. Roberts has given his rationale for not engaging, but I think we should ascertain from the trust, first of all, or the department, just who they engaged with, the numbers of the engagement, and the numbers of people who, like Mr. Roberts, who weren't involved in the engagement. Okay. So also last week we are informed by officials that the Department of Finance would be responsible for laying the LCM in relation to the Public Office Accountability Bill. Are members content that we schedule a briefing from the Department of Health officials once the LCM is laid?
Yeah.
Okay, so moving on then to the substance of our meeting. Item 5, oral briefing from the Royal College of Nurses. Can I refer members to tab 5, page 14 of the main pack? So can I welcome Breach Quinn, RCN NI Board Chair, Professor Rita Devlin, RCN Executive Director, and Dolores McCormick, RCN Associate Director. So these are all very welcome. Thanks for coming. We've got your briefing and initial comments. If you just want to give us a slight overview, and then we'll go straight to questions from members.
Thank you. Okay, that's me. All right. Thank you very much.
Away.
Hello, everybody. Good to see you, and thank you again for the opportunity. Thank you for allowing us to brief the committee on the issues addressed in our Pathway to Progression, Band 5 to 6 Career Progression for Nursing report that was published in May 2025. As you know, the report was shared with the committee and tabled for information at the time of publication. It was then discussed during an oral evidence session with the Department of Health officials on workforce issues at the committee meeting on the 15th of May. The invitation to brief the committee more fully was then extended to the RCN. We have provided you with a written briefing that summarises the key themes of the report and brings you up to date with various developments since it was published. We believe that the Agenda for Change framework dating from 2004 does not accurately reflect the relative job weighting of the realities, complexities and development trajectories of nursing as a graduate profession. We also believe that the framework neither enables nor promotes the recruitment, retention and motivation of nursing staff. Nursing deserves a career structure that supports clear progression with appropriate reward in order to recognise skills, competence, expertise and the greater responsibilities assumed while keeping care close to the patient. Our report sets out the case for why newly registered nurses following a period of preceptorship should therefore progress from Agenda for Change Band 5 to Band 6. The ability to progress in nursing careers is essential to maintaining safe staffing levels. The fact that around 50% of nurses in Northern Ireland practising within the HSE do so at Band 5 levels shows the inequality that our profession experiences. As you know, the HSE Reset Plan published by the Minister during the summer seeks to shift care, where appropriate, from hospitals to the community, embrace digital transformation and rebalance the focus away from simply treating ill health to promoting prevention and early intervention. The benefits of establishing a pathway to progression for nursing between Band 5 and Band 6 will, in our judgment, help enable the Department of Health to meet these objectives and deliver the Minister's vision. Following the publication of our report in May, we met the Health Minister and welcomed his stated support for ensuring that nurses are fully and appropriately recognised and remunerated for the work that they do. Our discussion was highly constructive and we agreed the following 3 measures. To work in collaboration with the Chief Nursing Officer and the Department of Health Director of Workforce Policy on the Career Progression Framework for Nursing and to establish how this will link with ensuring that nursing roles are appropriately recognised and remunerated. Secondly, to explore with the Department of Health the application within the nursing profession in Northern Ireland of the provisions of Annex 20 of the NHS Terms and Conditions of Service Handbook on the development of professional roles. Thirdly, the RCN is undertaking a survey of members to explore the reality of professional roles in relation to current banding, and we will share the outcomes with the Department of Health and this committee to help inform the wider discussion. In addition, as members will be aware, the Minister told the Assembly just last week in response to a topical question, and I quote, "We need to look particularly at promotion from Band 5 to Band 6 and 7 because you can qualify as a Band 5 nurse, have a long and very successful career and retire at a Band 5 nurse. We have to look at ways of promoting nurses from Band 5 through to Band 6 and Band 7. There is a whole basket of issues beyond money. It is about job satisfaction." End of quote. We hope that the committee will find this session helpful. We believe that recognising, supporting, facilitating and appropriately rewarding our nursing staff would make an invaluable contribution to addressing the underlying crisis within our health and social care system in Northern Ireland and improving the health and well-being of the people of Northern Ireland. Thank you very much.
Thank you. So, just on the point that you finished, because at this committee, when we're getting a briefing from whatever sector within the health workforce is a key problem, obviously the nursing profession makes up the biggest proportion of our healthcare workers, so that's an added extent to it. So, Bridge, you talked about engagement with the Minister since May on 3 issues, and you articulated his response in the Chamber the other day. I mean, what kind of progress has been made with the Department on those 3 aspects of discussion?
Yes, Rita.
Thanks very much, Philip. I suppose the discussion with the Minister came about because we wrote to the Minister after the report and we asked for a meeting to discuss the Band 5, Band 6 report and what was contained in it. And I have to say, the response that I got from, it was signed by the Minister, but I know it was a civil service response, was the response that really, for me, identifies the lack of value for nursing. So basically what it said was there will be places where it is Band 5 nurses that are required to look after patients. Now, what I would say there is no evidence to suggest that nursing is a Band 5 profession. There is no evidence to suggest that patients require the work of a Band 5. What the evidence shows us is that patients are much more complex, they are sicker, the treatments are more complex, they're more dangerous, we're managing much more risk. And for somebody to come out and say that nursing is a Band 5 profession, who has has never spent a day as a nurse in their lives, that made us really cross, as you can imagine. So we did meet with the Minister and explain the issues with him, and I have to say he did take that very well. He took the challenge quite well. So we have met with him. The work is being progressed through the Chief Nursing Officer and the piece of work that's being done. If you remember, it was the Nursing Midwifery Task Group that came out around about 2020, and it identified in it the absolute requirement for career progression for nurses. And that report has since had a few iterations, and we're working with the chief nurse now. However, for me, I think the difficulty is that there is this idea that because, and I think it all comes down to money, because nursing is the biggest part of the profession. If you think 50% of nurses are at a Band 5, to uplift those nurses from a Band 5 to a Band 6 will have a financial implication.
Do we know what that would be?
So, Dolores, you've worked out from a 5 to 6, it's about £7,000 per nurse.
Okay. And how many? So you're talking?
We're probably talking around about 8 to 10,000. So there is a significant cost here. However, we believe that nursing should not be seen as a cost. It should be seen as an absolute. It's a benefit to patients because if you have nurses who are highly motivated, highly skilled, and working and feel valued, what they do is that they reduce the cost of care. So poor care costs a lot more money than good care. Because if you have nurses, we are the safety critical profession, so we're the people who are there to make sure that patients get better, get the proper treatment on time, that we notice and identify deterioration, that we notice and identify hospital-acquired infections, hospital-acquired pressure sores, all of those things that cost the health service a fortune. And I know the last compensation bill for health in Northern Ireland was absolutely massive. So nursing shouldn't be seen as a cost. It should be seen as something that is there to prevent and actually enhance care, and therefore in the longer term save money. So we do believe, there are 3 reasons I believe why nursing is in the positions it's in. First of all, it's a female population, a working population, 92% are female. So there's a gender issue there. There's also the issue around it seemed to be women's work and anybody can do it, so there's no knowledge, skills or expertise. Anybody can turn up and be a nurse, and that some people still have that view of the world. I'd ask them to work in a ward for a couple of weeks and see if that still holds view. And then there's the other issue which I've sort of said to you about cost. So for us this is kind of trying to draw a line in the sand here and get nursing to where it needs to be. We're not asking for a lot, but we're asking for recognition of the profession and how it has changed. So Agenda for Change was implemented in 2004. Nursing wasn't even a degree profession in 2004. So it has significant, I mean, from when I was a student nurse, it is unrecognisable.
Just explain some of the changes maybe from 2004 to now.
Well, I suppose what I would say, so first of all, it's a much more complex, so treatments are more complex. If you look at any current treatment, for example, for chemotherapy, neonatal, children's, everything is much more complex. And what nurses are doing there, they're the kind of people who look after the patients when the treatments are ongoing. We have people, and let's face it, we have people who are living now who would not have lived 20 years ago. We have a very high level of dementia and confusion. And that in itself is a huge issue for nursing, because nurses are the people who look after those people. You don't see anybody else then looking after those people. It is the nurses. And really the comorbidities that patients have, the complexities, the fact that we now have people who are being operated on, those operations never would have happened maybe 20 years ago. And so those patients, when they come out of theatre, are very ill for a long time and require an awful lot of nursing care. So we also have patients in the community who, when I was a nurse working on the wards, would have been in intensive care, and they're now being looked after at home with all kinds of equipment. So nursing in no way represents now, the Band 5 no way represents what nurses do now.
See in terms of, I mean, because in your briefing paper, sorry, I should actually say your briefing paper was very good about pointing out some of the inequalities.
Yeah.
And I mean, you talked about the letter in response initially that drove your engagement with the Minister. I mean, certainly nobody in this committee undervalues the role of nurses. You talked about career progression in Scotland moving forward. Can I ask what and I'm asking it because, again, on this island, workforce is in conflict north and south, and we have a lot of people in the health profession working in the south. So can I ask, in terms of nurses, what's the position in the south and how is that impacting? So
in Scotland, as you know, the Band 5s were, as part of the pay uplift in so all the Band 5 nurses are now able to have a review of Band 5, and 3 out of 4 of them are being uplifted to Band 6, where they can finish the process. In the Republic of Ireland, what happens to the nurses there is once they graduate, they do a period of, I think it's 12 months, and they automatically are uplifted, and that uplift is probably worth about 7,000-8,000. Yeah. That's an automatic progression. Now, what they have to do is they have to fill in a form. Their ward sister has to fill in the form to say this person, because obviously if somebody wasn't meeting, you wouldn't want them to be uplifted until such times as they were ready to. What we're looking for in Northern Ireland is not necessarily an automatic progression with nothing. What we're looking for is a period of preceptorship and an identification of a set of competencies that once you've met those competencies at that level, you will then move on to Band 6.
I mean, could the department do that without much effort or work?
They absolutely could, but the problem is the cost. It all comes back to money here. I have absolutely no doubt. So we know that nurses, for example, Band 5 nurse is 11 times more likely to still be a Band 5 in 5 years than a physiotherapist, for example. We're not saying physiotherapists shouldn't be getting the Band 6. What we're saying is we should as well. Well, our nurses should as well. So that inequity has been there for quite a long time. And we have asked to have Annex 20. And Dolores, maybe do you want to explain what Annex 20 is?
Sorry, can I just before you do that, just one other thing I just want to mention, which I think is important when you go back to your question about Agenda for Change and what has changed. Agenda for Change came into being in 2004. From 2009 to get into the nurse training, you require to have a degree. Yeah. So in 2004, no degree was required. It is now a graduate profession. Mm-hmm. So, but nothing has changed in relation to pay or the run through. Okay, sorry.
And following on from that, our regulator has recognised the changes, as Rita was talking about, and the advancement of nursing, and came out in 2018 with, additional proficiency. So nurses are coming out now with a higher level of expertise than they would have been gone back, and that has not been recognised or reflected in their pay. Annex 20 then is the rock we're all perishing on. Annex 20, it is included in the NHS Terms and Conditions of Service Handbook, and that describes a route for the provision of professional development. So it allows someone, a graduate coming out of the Band 5, to progress through. For example, I'll give an example. Midwives come out as Band 5s. Annex 20 then is a provision that's in there in the handbook that will allow them to progress through, in the way that Rita described, through a competency framework. It doesn't work for nursing. Don't ask us why. We would love to know the answer to that. But it works for routinely works for midwives and paramedics and social workers. But for our nursing staff, if I'm a Band 5 nurse, the only way I get a Band 6 is at the minute is I have to wait for a job to be advertised and I have to go through a recruitment. The other avenue open to me is to ask for my job to be re-evaluated, and there is in the briefing we do talk about the job evaluation process. It's a very broken process in Northern Ireland. It's very difficult to get through it. It's probably not well resourced across the piece, and very often what we're finding, and we've plenty of evidence to support this, is we have nurses who have difficulty getting their job description signed off by their managers, and it's all down to money, and then we have difficulty getting them through panels. So we don't find, our experience is the job evaluation process does not work very very seamlessly for nursing. But Annex 20, I suppose our biggest issue is that Annex 20 is not available to nursing staff at this time.
Yeah, and that's been helpful. So obviously there's other members. I have a pile of questions on this and on other questions, but I'm going to. But before I do, because it's kind of connected. So you'll have heard the debate the other day with regard to pay. So a bit of positivity. Everybody wants to see it being resolved. Everybody's hopeful that it's resolved, even from within the executive. That seemed to be the indication. So I just wanted to allow you the opportunity to maybe update us on that issue from your point of view.
Well, we listened, and it was very heartening to hear all the parties actually identifying their value for nursing, and we are very hopeful. Obviously, until we get pen to paper, and we will obviously continue our preparations for action. But it was very hopeful, and actually, as a citizen, what was very hopeful, I think, was the fact that all of the parties were working together, and I think that for me, as a citizen of Northern Ireland, felt very good and hopeful.
Okay, so well, hopefully it will be resolved. And quickly, Danny.
Thank you, Chair. And first, obviously, I've declared interest as a nurse, Band 5 bank nurse at the minute, but I've been Band 5 and Band 6 at the South and Eastern Trust for many years. Nursing is a safety critical profession, as you say. This is a public safety issue. A couple of the things that jumped out at me just about how important it is for nurses. The risk of death of patients increases by up to 41% when there are fewer registered nurses on the ward. Like, that is shocking. And patients are also 20% more likely to be readmitted and 41% more likely to stay longer in hospital under these circumstances. So the more nurses we have, the better patients are, the quicker they get better, the less time they spend in hospital or need to spend in hospital. So it's clear, the importance of that. A couple of questions. The first one you raised about the gender issue. It's a 91% female workforce. Not all, there's another 9%. But does this, in your opinion, do you think this breaches the department's Section 75 duties? And has the RCN contacted the Equality Commission about this at all?
I suppose this is an issue right across the UK, so it's not a specific Northern Ireland issue. And yes, we have looked at that from an equality point of view. It's very difficult to prove. It's very difficult to prove that because they look at Agenda for Change and they look at the Agenda for Change process, and they would say that the nurses are banded according to Agenda for Change, but they're not taken into account as Agenda for Change has never been re-evaluated since 2004, so therefore you're working on an old system that is actually our challenges with the Agenda for Change banding process. So yes, it is an avenue that we've thought about, but it would be very difficult to prove at this point in time that it is,
As an issue of fairness with those other comparable professions that you mentioned, and certainly I have colleagues in those professions, in paramedicine, social work, and midwifery, who are able to avail of that that progress within a couple of years of graduation. Nurses aren't. There's a huge issue of fairness then, that nursing appears not to be valued in the same way that those other professions are.
None of this is against our other professions, because actually we believe they're in the right place and we're in the wrong place. But if you think about it, a physiotherapist sees one patient at a time. You think of a band 5 nurse working probably at night, probably 16, 18 patients, maybe one nurse, one healthcare assistant, multiple different requirements for those patients. So are you telling me that a physiotherapist is worth more than a band 5, than a nurse in that situation? Because that's really what Agenda for Change is saying, that their knowledge, skills and expertise is worth more than a nurse's. And that's where we have great difficulty with. As I say, this is not about the other professions. They have luckily got what they deserve. We believe that we haven't, and that's why we're fighting for this. Just a few statistics, Danny, that might make you a wee bit cross. If you look in 2025 in Northern Ireland, 11.4% of admin and clerical were at band 5. In nursing, it's 49%. Professional and technical, which includes our AHPs, 14% of them are at band 5. As I've said, in nursing, 49%. If you look at band 8 then, so this inequality actually goes right through the band. So if you look admin and clerical, band 8, there's over 10%. Professional and technical at band 8, there's over 13%. Nursing and midwifery, 4%. So this inequity actually goes right through all the banding of nursing right across. So for us, the band 5 to 6, actually the career progression is only the starting point for us. But if you think that those nurses, some of those band 5 nurses are maybe coming home with £1,500 a month for what they do. So for us, it is an injustice, and we feel very strongly it's an injustice. And we feel very strongly that we will do everything we can to try to get this injustice rectified for our nurses.
You touched on something there that I wanted to ask you about as well in your previous bit, just about the payouts from health and healthcare trusts recently. My colleague Kelly Armstrong had written to the Health Minister and asked just about out-of-court pay settlements. And I think the total over the last 15 years has been 180 million, which is a shocking amount. I mean, we've talked about the cost of doing this, but when you look at the costs that are being paid out, we really have to look at where this money is going and where this money is being lost.
You're absolutely right. And one of the big issues for us is the number of early career nurses that we're now losing at second year. And the reason we're losing them at second year is because there is no career progression for them. So if you look at the adverts that are being for independent sector, for example, for the new private hospitals, etc., they'll not be paying them band 5. They'll be paying them a lot more.
Sorry to come in there, because I listened to the Education Minister the other day whenever the announcement was made about the, paying fees for certain teachers and subjects, and he actually made the point that the 2-year limit, there's statistics that prove that when they get teachers in for 2 years, they become settled and they don't move on. It's probably within the first 2 years. So when I read that in your briefing, I was a bit shocked that nurses is actually the opposite, that they're leaving.
But teachers get paid for everything they do. If they take on some other duties outside of their own, they get paid for that.
Yeah.
So they get remunerated for extra activities, extra experience. Nursing don't.
No, and it's clear now from what he said and what you're saying that there's obviously good reasons why it's happening one way in one and not happening in the profession of nurses. Sorry, Danny, I just wanted to raise that point.
Well, you're grand, you're just right. Can I just ask as well, you said that many band 5 posts are actually doing band 6 and band 7 jobs or tasks. Can you give any examples of that?
So we met recently, we were up in one of the trusts, and we met neonatal nurses who are looking after the tiniest, most vulnerable babies. They all have their neonatal course and they're being paid a band 5. A band 5 should be a graduate job where you come straight out of university. You should not have to do extra courses to get a band 5, yet some of those nurses have been neonatal specialist nurses being paid at band 5 for years. So if they were to take their knowledge, skills and expertise and move elsewhere, that would be a huge issue. So they are actually, as far as I'm concerned, being taken advantage of. Nurses with chemotherapy courses, being paid band 5, nurses doing advanced. But even nurses looking after, I don't mean even, but nurses looking after our oldest and most vulnerable patients, the amount of knowledge, skills and expertise that it takes to look after those patients, and it's totally devalued because they're old people and anybody can look after old people. So it's totally devalued, and that is I suppose that's the issue for us that makes us really so angry about the situation that we are finding ourselves in.
It's just a pattern that's repeated right across the whole system. Community nurses out on their own, band 5 nurses. When we qualified, you wouldn't have got a job out in the community till you had about so many years' experience under your belt. And the complexities of the care that they're delivering out in the community. We have a great example of a team in the Northern Trust who have diverted so many patients, hospital diversion team. Yeah. Their clinical skills are second to none. Out there on their own, delivering highly clinically, highly therapeutic skills, and we cannot get them uplifted to a band 5. And they have, if we're talking money, they have saved so many hospital days. So, and that is, we have so many examples. We're actually working on, we talk about the survey, we're working on that survey and we're talking to nurses about what they're doing. Band 5 nurses regularly take charge of shifts, run wards on their own. Yeah. And you take your band 5s out of the hospital, your health service will just go.
And I think that's why the Minister was so alarmed when we said about our industrial action, because we only need to take band 5s out and the place will grind to a halt, because they're the ones doing the majority of the work.
It clearly has an impact on recruitment and retention of key element of health service staff here. Can I just ask just briefly, currently there are 1,819 vacant posts according to Department of Health data. Just with recent graduation there, obviously we've had a lot of nursing grads. Do we know how many of them have taken up full-time posts, and are there any of them are having trouble getting full-time posts within trusts?
There were they were reporting some difficulties because some trusts, so some of the issues that we're having is some of the trusts are not recruiting to all their vacancies because there's a cost saving going on at the minute. So that's one of the issues that we need to think about.
Not recruiting to all their vacancies?
There was an issue where some of them weren't. Now we have obviously had, we have challenged the Department of Health, and and we're keeping track of the trusts, and we're being assured that all posts are going through scrutiny, all nursing posts. The issue for us is some of those vacancies are band 6 vacancies, and we would argue we should not have band 6 vacancies because we have a steady stream of nurses who are able to go into Band 6, but these Band 6 vacancies aren't being filled at the minute because they're out for recruitment or going through scrutiny or whatever it is. So there's an inequity there, because on the one hand we're being told we've had so many vacancies, on the other hand our nurses are struggling to get jobs. So we're on top of that and trying to make sure that that's not the case. And we do challenge the trusts. We've also challenged the trusts on job descriptions recently that have come out at Band 5 that are asking for over and above a Band 5. And we're having some success with that. And the issue, I suppose, for us is as well that if you look around the trusts and the overcrowding and the extra beds, a lot of those extra beds are not funded. So we do not have enough nurses to look after we may have enough nurses to look after the funded patients, but we certainly don't have enough nurses to look after the unfunded extra beds. One of the wards we're told now has 6 extra beds every day. Every ward, 6 extra beds.
I've seen that, and I've worked on those wards.
So 6 extra beds without extra staff, or if they do have extra staff, they're agency staff. So there are huge issues. We have spoken to the trusts and told, they should be over recruiting, because the need is there. It's definitely there.
With those vacancies, there shouldn't be nursing graduates in Northern Ireland.
There shouldn't be.
We're having trouble finding a job.
Now, the issue, and we have to be fair here, the issue is some of the nurses want to hold on for their specific area. So some want to work in intensive care, some want to work, and if there aren't vacancies there, well, there aren't vacancies. But in general, we try to encourage our nurses to take a job where they can get it and then move around when the time comes.
We have followed that closely, so in fairness to the trusts, we're not in the same position as we were last year with the graduates, and I do believe, bar, as Rita said, those that are holding out for a particular clinical specialism, some of the trusts are actually recruiting them in at risk and are devising like an induction programme to put them onto a bank or whatever, although we would have thought they should have been posts, but anyway, we're not in the situation that we were in last year with our graduates.
And to be fair to the trust, we are working very closely with them and the Department of Health and the chief nurse in and around that whole area around graduate recruitment.
Good to hear. That's fantastic. Thank you very much.
Thanks.
Thanks, Chair, and thank you for the presentation. The Chair had touched upon a point that I wanted to raise, and that was regards to Scotland and their current review of Band 5 nursing. Obviously, there will be other jurisdictions where there are progression pathways, and I suppose it was one to ask, what is the hard figures or hard evidence of how those progression pathways have improved nurse retention rates in those jurisdictions?
And I suppose it's very difficult to give you that response, Alan, because in Scotland it's only just started. I think Scotland there's a couple of thousand through, I think, at the minute, but they haven't finished. The process is so long and drawn out that if for a nurse to apply for an uplift or for a review of her job, it can take anything up to 2 years, 3 years. So Scotland has only just started. I think they've a couple of hundred through, but 3 out of 4 have been uplifted to the 6, which demonstrates that they're working at that level in their post. The evidence to support the difference between the 5 and 6 doesn't exist at the minute, because we have not been able to challenge the view that nursing is not a Band 5 profession. So therefore nurses are sort of bundled in together, and it's the work that they do would be evaluated as opposed to the grade that they're at or what grade had been working at that particular time. So the evidence wouldn't be there for now. In the Republic of Ireland, where they have moved from the 5 through their they don't have a 5 to 6 through their proficiencies through to the higher level of pay. What they are seeing then is a decrease in people leaving, and their decrease in then their reliance on international recruitment, and so therefore, but they're in a bit of a different position in that they haven't recruited enough nurses to look after the population. So they're in a sort of a catch-up position where they're trying to recruit more nurses, more students, and train more students. And that's why we got if you remember, we got the 50 this year and so many the year before. So whilst they're in a position of nurses getting automatically uplifted, they're in a position where they don't have the workforce that they need to look after their patients. So it's very hard to extrapolate the higher level nurse from the vacancy
Their
factor.
problem is actually creating our problem because they will be recruiting from the north.
Absolutely.
Yeah.
That is the risk. And I think also just to add to what Rita has said there, even though the evidence is not there yet, and obviously we are watching that space very, very closely and very carefully, all and any investment in nursing will result in improvement in patient care, greater standards and retention. It makes sense if people are leaving to seek higher pay elsewhere. If we can do that here and keep people in Northern Ireland, it makes sense that we should do so.
Can I just ask a question just on the back of the debate that we had? A member, quote, had said that nurses are using food banks and they're homeless.
Mm-hmm.
Is that something that you recognise? Because that is shock. Is that a
So we've had a few, mostly student nurses that we've been told have had to use food banks because the student bursary is only about 4,500, I think. That's all the student bursary is. So we have evidence. Some of I think people think of student nurses as being young out of school people. They're absolutely not. They're more and more. They're more mature people with families who have maybe given up jobs to come and do training for student nurse. And yes, some of them are very lowly paid. You think if you were to give up your salary, if you have a couple of children and a mortgage, you're giving up your salary to be a nurse and go through 3 years of student nurses. Financially, they are it's very difficult for them, and we have seen some of those nurses have to leave, the student nurses, because they can't afford to do it. The food banks, I mean, I haven't had anybody come to us so far, but obviously people don't come to you if they're using food banks. We do know that people rely on sort of maybe food banks at the end of the month or whatever when their bursaries run out, but you have to remember as well, an awful lot of nurses are the breadwinners in their house. So if you're a band 5 nurse and you've got children, we all know the cost of childcare, first of all, the cost of travel, because nurses, as far as I know, healthcare staff are the only people who have to pay to go to work, so they have to pay for their parking. And that can be significant in some of our trusts, significant cost to them. And those are some of the issues then that we see, that not only is it a lower paid, the band 5 being very low paid, but the cost of trying to come to work and childcare really means that some people are struggling, particularly in areas now where rent, I mean, I don't know if any of you have noticed, but rent in Belfast is really, really extremely high at the minute and very difficult.
Yeah, the other thing, moving it slightly from the food banks, Alan, but we regularly talk to nurses as recent as this morning, and so many of our band 5 nurses, it's not a lucrative pay, okay? A lot of them then end up doing the agency shifts to get the extra money. There's another option where we're trying to regionalise the bank in Northern Ireland, and there's a conversation about prompter payments. So I'm talking to nurses today and I'm going, you're a substantive member of staff, you are entitled under that NHS terms and conditions to overtime if you work over and above your contract. And Danny's nodding. Many of them we'll not get into the conversation about whether they are or not being offered that, but many of them end up taking bank shifts, maybe at a band 5, and we'll be saying, you're entitled to overtime, why are you working bank shifts? Because in some trusts they can get paid at the end of the week because they need the money. So it's maybe not going to a food bank, but I'm picking up an extra shift because the agency can pay me quicker, or the bank in my trust can pay me by the end of the week, and that's where many of our members are. So they certainly are finding it tight.
Can I just ask one last question, Chair? The Minister quite rightly expressed his concern at the possibility of strike action, with the possibility of November At what point will we, and obviously the province and the Minister and his department, know when that decision will be made in terms of will there be strike action?
Well, I suppose I would say right back at you, the ball's in the court of the executive. So what we have said is that we've given till the end of September for any movement on pay. The debate was very heartening, I have to say, and we have, because none of us want to be in that position. However, because there's nothing on the table as yet, we will continue our preparation. So we would have to ballot members, and we will be going out to ballot members if nothing happens at the beginning of October, and we'll probably ballot for about 5 or 6 weeks. So it would be probably up mid-November, early December. But we're all hoping that we don't have to do that.
Absolutely. Clock's rapidly ticking.
Yeah,
Clock's ticking.
Okay, so there's 3 members left, and because of the time constraints today, I have to close the conversation down shortly after 3, so I'm just letting everybody know that. Linda, you're next.
Mine are a couple of points and a quick question. So the first thing is just to say, I've just looked it up. So for a Band 5 nurse, their take-home pay is almost £2,000. And I know you said about rent being very expensive in Belfast.
Yeah.
Rent in Coal Island is £1,000, so I can't begin to imagine what rent in Belfast would be. So, and many of our nurses are, not only are they the breadwinners and women, many of them are single parents. They have other care requirements where they're caring for elderly parents and children with additional needs. So I think it's just worth making that point because it is important, and it's important that we all understand that, and that everybody out there understands that this is not about some, everybody coming around looking more. This is a genuine issue. And I'm glad you've had good conversations with the Minister. I suppose, and I get your point about the civil service answer, but ministers sign off on every letter that goes out. So I think it is good that you've met with him since that he has taken on board your concerns. I think that's really important, because very often until you actually hear the reality from people like you, it's very hard to take that on and really get an understanding for the challenges that nurses, and understand the complexity that this is not straightforward. Sometimes something comes in front of you and you read it and you think, okay, that sounds reasonable, and then you hear your side of it and you realise that's not reasonable at all. So what I want to know is 2 things. First of all, what exactly would the Minister, I know Philip asked the question, how easy or difficult would it be for the Minister to move on this? I want to know what exactly the Minister, the Department would have to do, how it would be done, how long that might take. And we already know what the cost is. Probably you're talking about 70 million. When you do 10,000 by 7,000, that's 70 million. But you've also talked about a number of areas there where there would be potentially substantial savings. So it can't always, and I say this in relation to everything, I'm sick listening to myself, to be honest with you, it can't always be about more money. Sometimes it has to be about what you're using, how you're using what you have. So I do want us to get a better understanding, because our job is to hold the Minister and the Department to account, and we can only do that if we have the information. So with that information, we then maybe will be able to go back and say, here's what potentially could be done, here's how difficult it would be or how easy it would be, here's the cost, but here's the potential savings. So if we can just get a wee bit more around that.
So I think from our point of view, the first thing actually would be to recognise the fact that it's an issue, and to have, I suppose, a commitment to enabling us to move forward with looking at application of Annex 20 across nursing. Then what we would have to do is, if we could get that from buy-in from the Department of Health, then what we would have to do is to look at probably a structured process, because we'll have people at the top of Band 5 who've been there maybe for 10 years. So it might be that we look at, how long somebody has been a Band 5 first. But obviously, we want this to be a competency-based framework. So if somebody is not working to the level of a Band 6, then they shouldn't be getting a Band 6. So we're not asking for an automatic run through. What we're asking for is a career progression framework where, after I have done my year's preceptorship proficiency, that I work with my ward sister, charge nurse, whoever, and identify that I have met the proficiencies for that area, and then I can be signed off to move on to the Band 6. So we're probably talking about a process here as opposed to everybody at one stage all moving on to band 6. That's not what we're looking for here. And that process, I'm sure, will take because Agenda for Change took a long time to implement. So, we're not talking about a big bang overnight. We're talking about.
So old, I remember that.
We're talking about, an identification of the need, a process that works for everybody, application of Annex 20, and therefore, and within that, then we would have to have, built-in evaluation. What has happened? What difference has it made? What difference has it made to the profession in terms of recruitment, retention? Productivity. We need to look at productivity, but I would argue that nurses couldn't be any more productive because they are already looking after 2 patients where they only should be looking after 1. And I think, Linda, for us, it's very difficult for us to say if you give us more band 6s, the patients will get better outcomes, because there are so many factors that are impacting on patient health and well-being in Northern Ireland, not least the fact that the overcrowding, and not least the fact of the understaffing. So could we promise that there'd be a difference in patient outcomes? No, we couldn't. But what we could promise to do is to work to make sure that standards are rise and are maintained, and that patients or nurses are held accountable for the work that they do, if we have a proper process in place.
Sorry to jump in, but you're talking about outcomes for patients. I think in your briefing you talked about shortages within paediatric nursing, and our next presentation's about long lists in paediatric services. So more nurses will help. So patients do get outcomes.
Oh, absolutely.
That are positive.
I would certainly say if the Minister's transformation plan, if the nurses were involved in that, we could deliver on transformation. We could absolutely deliver on transformation. We could take some of the waste out of the system. But that requires, I think, identification of the value of nursing, and we do not have that at the minute. Between the band 5 issue, between the pay issue, between the fact that every year for I think 4 years we've had to threaten to go on the streets to get a proper pay. Do you know what I mean? So we have to be showing our nurses, you are a valued profession, and then we hold them to account for the delivery of that transformation agenda. So I think from our point of view, I think there's great scope for nurses to be much more productive in ways that would be helpful in terms of waiting list agenda, transformation agenda, the shift left agenda. But you have to have a valued workforce and a motivated workforce to do that.
And was that you?
Yeah, that is. Thank you very much.
Excellent.
Arlia?
Yes, thank you, Chair. So the first question, just quickly, it's more of a sort of general question, aside from the pay and the retention stuff. Just conscious then you're coming up to a potential cliff edge where you're having to take into consideration possibly going out and strike. We're also coming up to another winter period, and I know the system is under probably that strain all year round. I've heard that said many times, but it's just to ask the question in terms of then coming up to your winter pressures on top of the pressures you're already dealing with. What potential or damage, could that do to your workforce? Could that do to the system? I'm just trying to get a sense of where your members' heads are at, because we are coming up to the winter season again, and that's probably already a difficult time for everybody on top of this. That's the first question. And then the second one, you have mentioned something, Rita, around your members and your nurses who care for older people, and obviously how important and critical that job is. And it just made me think, because obviously then services, so your staff are working, already at a disadvantage because you haven't got enough staff, you haven't got the proper pay that you should be, the proper pay levels that you should be sitting at, and then the services themselves are underfunded. And it was just using that example, particularly around older people. And it worries me when I hear things like that, because I get the sense that, are we getting to the point that the focus is now becoming more around the system rather than the patients. And if your nurses aren't being supported to have the additional staff and support and pay that they need, I know that they do give their all, but it's just where we're at in terms of where our health, what our health system has become. And I'm not saying that to be critical, oh my God, of any of our workforce, but it's just people are obviously working in really difficult circumstances. And the final point was around the efficiency savings that you had mentioned. And I'm just wondering if you have any glaring examples that we could be, because we're constantly lobbying and discussing with the Minister and his officials and his finance team around efficiency savings, what can be done, how can we find more money then to put the value into the nurses. So do you have, or does your staff have a view of any glaring examples, because you are working in the heart of it every day, of where maybe things, there could be more efficiency savings on a day-to-day basis, so we can take that on board?
So I'll answer you the questions in terms of where our nurses are. It really astounds me that when we speak to our nurses, the thing, they would say about how busy it is, how short-staffed it is, how stressed they are, but every single one always says, I still love nursing and I still love looking after patients if I was allowed to do that. So from us, sometimes I wonder how, because the things that they have to go into every morning, I don't know how they get out of bed sometimes, particularly in those really dark days where there's 40 patients lying on a trolley, there's 6 extra patients on a ward, but they still love nursing. They don't like the system they work in. They don't like the environment they're being asked to work in. They don't like the fact that they cannot raise their head from they go in on a shift, come out on a shift. They don't like the fact that they have to walk past sick patients because there's just too many of them. So from that point of view, we still have that goodwill and that the people who love what to do. And for us, I think it's the challenge for us is to make the system better for them to work in. You talked about efficiency savings there earlier. You just have to look at our Nurse of the Year every year. I mean, it is just phenomenal the amount of things that nurses are doing with nothing. And I mean with nothing. With spirit, with enthusiasm, with just wanting to do things better. You just have, we can send you the brochures. Last year's Nurse of the Year was primary care, and the things that she was doing to keep people out of hospital was amazing. Mental health was just phenomenal. Taking care to where the patients are. Some of our community nurses are doing fabulous work in terms of, I was talking to one of the nurses last week, in terms of the farmers. Farmers won't go to hospital. Farmers won't go to GPs. You have to go to where the farmers are. Great stuff. Our nurses are doing lovely mental health stuff with the trucker, the lorry drivers, doing great work around mental health. Big high levels of depression within lorry drivers, high levels of heart disease, undiagnosed blood pressure. A truck up in Nuts Corner, I think they saw something like 350 truckers. They got their blood pressures done, they got all kinds of mental health, dietary, all of those things. It didn't cost anything because those nurses gave it of their free time. The reason they couldn't do it this year because they couldn't get funded to get up and get the truck. Couldn't get the truck. We're talking here, preventative medicine on one side and actually a couple of £1,000 that would have got through to all of those people. So there's loads of those. Our Nurse of the Year every year is just phenomenal in terms of what people can do with just a wee bit of encouragement and maybe some tiny seed funding. They're not looking for thousands of pounds, like seed funding, but we can give you any kind of loads of stuff, and we'll be just launching it again this year for next year. There's phenomenal work going on, unrecognised, unknown, but it's phenomenal.
So I suppose when you talk about efficiency savings, if you're talking about where do you take hard cash from and put it somewhere else, it's actually, when you look at the work that Rita has described, it's about early intervention. So it's preventing people from getting ill, and that's where the savings are made. So when people are intervening early, where people are actually saving lives, and when we talk about the mental health examples, people are actually saving lives, not just saving bed days, but actually saving lives. So that's the savings that are made, which isn't as tangible, but it's nonetheless it is making a huge difference. So I suppose when we talk about savings, we have to think outside the hard cash element of it.
I suppose the other thing, Orla, is following on from Rita there, what we find is we've particularly over COVID, there were so many nurse-led initiatives, or time and time again our winners come through to Nurse of the Year. The absence of the multi-year budget meant you got funding for a project, the project was really good, it had really good outcomes, and it went.
Yeah.
And the other thing is we've wonderful stuff happening in one trust, but the other trust doesn't learn. So there's so many things that nursing could do around, and if we had multi-year budgets that would absolutely help that, but even the learning across the piece.
The things that you're talking about there are just exactly what Shift Left should be about.
Yes.
And I mean, certainly I was privileged to be at your Nurse of the Year event, so I wouldn't say it was an eye-opener about some of the work. It's probably more an affirmation of the work that is going on.
And just on the winter pressure stuff, have you...
Well, they're already in place. I think this week, I think, has been shocking in the trusts. Lots of patients in EDs. As somebody said, 6 extra beds in Southeastern Trust, which was built as a brand spanking new hospital where patients were going to get, brilliant care, like hotel service, and now there's 6 of them lying in a corridor with 1 toilet between them. So we can't keep doing that. We can't keep trying to force a pint into a half-pint pot here. So. But at the same time, we don't have enough district nurses to get patients out of hospital. There's been a total lack of, funding in terms of that whole shift left, that whole community aspect, our district nurses, and there's work to be done in and around that with regards to that whole keeping people out of hospital.
Yeah. And again, it's important to say that we need to verbalise what's going on in hospital. We need to highlight that, because if nurses don't do that, who does do that? Because it's nurses that are at, they are the caregivers. They see what's happening and what should be happening and what isn't happening. And therefore, if we don't call that out, we're walking past that and accepting it, and we can't accept that. That is a standard we cannot accept as nurses. On all conscience, we can't accept it.
I've always said we're the canaries in the mine, but nobody listens.
Well, thank you for listening to us today. Thank you, appreciate it.
Okay, thanks, Colin.
Thank you, Chair. Thank you for the presentation. And once again, regrettably, I'm at the point of having to say, overworked, underpaid, but you had mentioned it earlier, Rita, undervalued. It's that sense that just as a profession you're not undervalued. And why does that happen? Because you compare yourself to everybody else and say, well, everybody else is getting, why aren't we? And that is something that will make the difference between whether you really want to go back in and work for that service on the basis of that. The two things, one, maybe just if you had a comment on, and the second was just, it may have been mentioned earlier and I didn't pick it up. What is the comparison to other regions in terms of England, Scotland, Wales, and the levels that they have at various levels, and are we drastically behind that? And then just a comment is, you're having to fight tooth and nail just to get the pay that you were actually promised, and it is actually rightfully yours. You were told in an almost promissory way, here is your pay, but we're holding it, we're not going to give it to you yet. And we'll see, as you say, that the proof in the pudding is going to be in the eating of that. But if that's what it's taking you to get what you're owed, what chance is there? What do you feel are your hopes of getting something that would actually require a review and actually require an admission that you once again have been underpaid? That's 70 million, about $7,000 per nurse extra. The pay uplift is about 1,700, and look at you have had to do to fight to get that. So how confident are you that this process might land with people, and just what's the comparator across the regions?
I suppose, Colin, I have to be confident.
Of course.
I have to, if we were to give up, we would all be in a sticky wicket. So we have to be confident, and it's great to be able to talk to the Health Committee and talk about what the issues are. That is really great for us. And to be fair to the Minister, he has had once I put him right in a few things, he has had, you know, a good listening ear for this. And the other thing that we did talk to the Permanent Secretary as well, and he's very keen with the new 3-year budget that we look at not just pay, but we look at terms and conditions as well. So we are hopeful that there will be a piece of work done. We are, England has the lowest number of band 5s. Wales are slightly with England. They're around about 40-odd%. We are the next, and then Scotland has the highest. We have 50%. Scotland had 54%. But as we know, Scotland are now going through a process. So it is a UK-wide. It's an agenda for change problem, because agenda for change is supposed to be equal work for equal pay, or equal of pay for equal value of work. I don't understand how, when they designed Agenda for Change, they could ever see how nursing could be aligned with admin, could be aligned with something else. I mean, they're all professions in their own right. So I think it's Agenda for Change we have the problem with, and we will hopefully work. I know there's a big focus on Westminster, and Nicola, my Gen Sec at the minute, is talking to West Reading about exactly the same thing, about the band 5 to 6, and they're in negotiations with that. So, and I know the Minister has written to say that any negotiations, he wants to make sure there's a Northern Ireland voice on that. It's going through the Staff Council as well, so he is very clear that he wants that to be, which is very positive for us as well. So it is a battle that I'm sure that we'll have to keep fighting, but
it's good for us to know where you're having this, because we can back that up. If you're saying like that the Permanent Secretary said it should be looking at the 3-year budgets and about terms and conditions, that's something that we can raise if he's here then. So that's
I know he was very forthright about, you know, the idea that, I mean, every year, if we have to fight for pay every year, but every year that we fight for a pay uplift, everybody gets a pay uplift. It keeps us in the same position. It doesn't, any pay uplift doesn't help with the inequity that we feel that is on nursing. So if that makes sense, we're trying not to focus so much on the pay uplift. Well, obviously this year we are, but in the future, we, you know, if nurses were paid for the work that they do, that's what we're looking for moving forward for the future.
And we do have the Permanent Secretary here next week on the reset plan, so we can ask. That's a quick opportunity to ask. So very briefly, just one question that's outside of this. I mean, we've raised on here a number of times, I mean, the shockingly high levels of aggression and abuse, threats, violence against healthcare workers, nurses in particular, and then unfortunately recently we've had that extended to racist threats and whatnot. So body cam trial, any early indication of success otherwise?
So the body cam trial started on the 1st September, I think it was, in the Northern Trust. And speaking to some of our nursing staff in the Trust, early indications are that it most certainly does seem to be working as a deterrent. The nurses we spoke to are content with the policy, the process. No one is forced to wear the body cam. You only activate it if there's an escalation of violence or aggression. And they're certainly saying that, how do I describe it? Some ED departments have people who are in and out quite often, and the regular people that might be prone to outbreaks are certainly, they're stopping in their tracks. So their early indications are it's positive. It's not the panacea for all our ills, as you know, around violence and aggression. It's one small wee tool in the pack, and it's the whole implementation of the MOVA, you know, the Management of Violence and Aggression framework that was issued by the department back in 23, is where our focus is, as well as monitoring the impact. So I don't know if that answers your question.
That's good to hear. We will obviously get a fuller observation of it when it's finished, but I mean, that's an issue that the committee has certainly taken seriously, and we will continue to take that issue very seriously.
We're happy to come back if you want on the management of violence and aggression, because it's a
If I could just add one more thing, I know we're here to talk about band 5, 6 nurses, but our healthcare support workers who work within our wards and community are also totally undervalued as well. So I mean, we have our band, a lot of our healthcare assistants are paid at band 2, which is shocking for what they do. we have a big issue now with recruitment into that whole band 5 or band 2, band 3 healthcare. Nurses cannot work without the healthcare support workers. They can't do it. And we are really struggling. I think year on year we're seeing a bigger issue with not being able to recruit to that post, because you can go to Tesco or Iceland or Primark and get more money for no responsibility. So whilst the band 5 to 6 is really important to us, so is the band 2 to 3 automatic progression, and maybe we can have a conversation about that some other time. But
and we'll raise that issue next week. I mean, that's a big issue that everybody on this committee, but also from a constituency MLA point of view, is getting. And it is totally agree.
It is really worrying, and as I say, nurses can't do without the healthcare support workers.
Absolutely.
It is just, I mean, they are the lifeblood.
Patients can't do without.
Patients can't do without them.
And the agency usage in the band 2, band 3 is increasing. You know, hours wise, it's increasing.
So, ladies, we've went way over time there. Thank you very much, Breach, Rita, Dolores. Thank you very much, and
thank you.
Good luck and all
Thanks
that.
for listening.
Thank
you.
Thanks.
Hopefully, we'll see you when we get our pay. We'll
Yep.
have a celebration. Thank you.
Thank you.
Thank you. What to do in the back of that? No? Okay, members, next then is oral briefing from the department on paediatric waiting lists. So we'll just wait. So page 50 of main pack is where we'll find all the information. We'll just wait. There's maybe sorting of issues out there in the corridor as they meet the RCN. So can I just welcome Professor Mark Taylor, Regional Clinical Director of Elective Care, Paula Tweedy, Co-Director of Hospital Care, Joanne Elliott, Interim Director of Elective Care and Cancer Policy, and Paul Kavanagh, Director of Hospital Care. So you're all very welcome. It was the second meeting in a short period of time for some. So we've received the documentation. Happy to hand over to yourselves for a few minutes just in terms of a briefing, and then we'll go straight to questions. And we're aware some of you need the way.
Chair, I'm going to do some opening remarks if that's okay. Yep. Chair, members of the committee, thank you for the opportunity to brief you today. This session is focused on paediatric waiting times, and I will come to that in detail, but first it's important to set the wider context by outlining what is happening across elective care more generally. Reducing waiting lists has been one of our greatest challenges. The reasons are clear: rising demand, years of financial constraint and a slower pace of reform than is needed. We are equally clear that doing more of the same will not deliver the change that patients need. This is why the Department's elective care framework, published in May 2024, sets out a plan for a system that is sustainable, equitable and efficient. It covers service transformation, backlog clearance, productivity, workforce, independent sector engagement and patient communication. In 25-26, the Executive has ring-fenced up to 215 million for waiting list activity, although only 50 million of this represents new non-recurrent money. With an increased focus on productivity, we may be able to contribute some of this total to the overall health budget deficit this financial year, while still meeting our targets as outlined in the programme for government. The challenge is still significant and there will be no quick fix, but there are encouraging signs. For patients awaiting outpatient assessment and projected to be waiting over 4 years by the 31st of March 2026, there's been a 20% reduction between March 25 and August 25 for this cohort of patients. For patients awaiting an inpatient or day case procedure and projected to be waiting over 4 years in March 2026, there's been a 27% reduction in the same period. For some procedures, including gallbladder and tonsillectomy surgery, where no patient is expected to wait beyond 4 years by March 31st, 2026, reductions are closer to 35% for the same period. Endoscopy is showing real progress too. At its peak in 2022, nearly 40,000 patients were waiting. Since then, the symptomatic backlog has almost halved, and the planned backlog has fallen by nearly 70%. These improvements have been achieved through list validation, additional in-house activity and targeted use of the independent sector. 85 million of funding for red flag and time-critical capacity is being directed into vulnerable services such as gynaecology, urology, breast and diagnostics. While the Department and Trusts are working to get the recurrent capacity on the ground, funding is being used in year to continue our waiting list initiatives. 38 million has been allocated to waiting list initiatives in the first half of this year, and by June, Trusts had completed almost 59,000 assessments, diagnostic tests and procedures. A further 50 million in non-recurrent funding is being targeted at our long waiting patients. The waiting list reimbursement scheme, which launched in June, has already had over 300 applications, mostly in orthopaedics, and the scheme has now been expanded to enable eligible patients to seek treatment in EU countries. Ring-fenced investment has also enabled expansion of training places, with 7 new anaesthetic trainees who joined in August, and this is a vital step in staffing the additional capacity that we are building. And our clinical leadership is central, and the appointment of Professor Mark Taylor as our first Regional Clinical Director for Elective Care is a significant step, and I'm delighted that he joins us today. Turning now to paediatrics, waiting times for children and young people in Northern Ireland are deeply concerning. In some cases, children have waited many years for hospital admission or surgery, and this is a wholly unacceptable position. The Royal College of Paediatrics and Child Health's Worried and Waiting report highlights that Northern Ireland has some of the worst paediatric waiting times in the UK. And it also makes the point that for children, time is relative. Many treatments must occur within key developmental stages, and delays can have lasting impacts. The College has also acknowledged that the Child Health Partnership is the right vehicle for reform, but that this partnership requires additional resources, workforce planning and better use of data. The Department remains committed to reducing paediatric waiting times across outpatients, day case and inpatient services. Progress has already been made in several areas through the regional collaboration, elective funding and standardisation of pathways. Some of the new elective models of care are already being applied in children's services. In gastrostomy, a regional pathway has added theatre capacity and has reduced the PEG tube waiting list from 94 children in August to 94 children in April to just 14 in August, with further surgery scheduled. In ENT, direct tonsillectomy day case lists are cutting unnecessary outpatient appointments, and regional triage is ensuring that patients are seen by the most appropriate clinician. In plastics, centralised lists at the Ulster Hospital will free capacity in the Children's Hospital for complex cases. In ophthalmology, regionalisation and pre-assessment are in place, with new theatre lists planned to reduce waits for squint surgery to 13 weeks by March 2026. Beyond these examples, we have a new paediatric surgeon who is appointed with elective funding, as well as providing additional capacity for PEG tubes. The consultant has been working across multiple hospital sites, providing 3 additional theatre sessions per week, and this is already reducing the inpatient and day case waiting list by 10%. Recruitment of additional anaesthetic staff is underway to support theatre capacity. But at the same time, we must be candid about the priority areas that still require medium-term reform. In scoliosis, our local progress has been constrained by workforce shortages. A medium-term plan is now in place to commission additional procedures per year through NHS partners, while Belfast Trust builds its own capacity. In allergy services, demand has risen sharply, and a business case is being developed to expand the Children's Hospital team by 2 consultants supported by a trainee. This will allow 500 additional children to be seen each year and underpin delivery of new NICE treatments such as Palforzia. So while the scale of the challenge is clear, there are examples that show what can be achieved with the right investment, workforce and regional collaboration, and by applying the same reform models to children's services as we are using across elective care more broadly. Looking ahead, our focus is on reform, ensuring that children and young people as well as adults receive timely, safe and effective care, but lasting progress depends on certainty of funding. Non-recurrent allocations will only ever deliver short-term gain, but stability is essential if we are to expand core capacity, recruit and train staff and transform our services at scale. Colleagues will be happy to answer any questions. Thank you very much.
Thank you. So I have a few questions just on the back of that. In terms of the 215 million that the Executive Programme for Government has set aside for waiting lists, how much of that is for paediatric waiting lists?
I don't think it's not specifically for paediatric waiting lists, but Paul, I don't think there's any specific figure against paediatrics.
And I think that's something we would like to look at going forward, because the funding has been split by red flags and time critical, and of course for very few children who are actually a red flag. We only have about 25 cancers a year in Northern Ireland with children, so identifying children, you know, as one of the red flag priorities. Of course they are time critical, and as we start to work through with our waiting list now, going forward, we'd like to be able to invest more money in children's services, and maybe have a look at how we allocate our funding to make sure that children receive the 25% due that they should have, because they're 25% of our population.
Okay. Wasn't the answer I was expecting. So, Mark, this is your first time before the Health Committee, so before we'll all have probably a lot of questions for you in relation to this, but before you do, I'd like to maybe just offer you the opportunity to outline what your role is and what you see your role doing in relation to reducing waiting lists.
Thanks very much, Chair, and it's a pleasure to be here, and I do hope that I'm back repeatedly with progress. As Chair has said, this role is Regional Clinical Director for Elective Care, and in Northern Ireland that comes with the fact that we really have to deal with our waiting lists. They're unacceptable. They're unacceptable at paediatric level. They're unacceptable at adult level. And therefore, whilst the role is very similar to England, Scotland, Wales and Southern Ireland, in this jurisdiction, I suppose a lot of my activity will be based around elective productivity, efficiency, and I've met some of the Health Committee before, and I to try and make it, I suppose, as clear a remit, working very closely with the Minister to deal with the waiting lists. I see it as a sort of three-channeled approach, or three doors. Forgive me for always going back to the Mater Hospital, but the old convent door in the new build, if we imagine three of those, the first, where there is definite work to be done, but it's a longer game, is that of variance of practice within hospitals. And that's a multitude of issues: theatre starts, theatre finishes, numbers at clinics, practice, stepping up best practice throughout Northern Ireland, even initiatives like adding an extra person to every clinic for each clinician, given that we have so much back pressure. The second arch is that of additional work, waiting list initiative work, Saturdays and Sundays, evenings, whatever that may be, and that is that the same clinicians that are working during the day, we want to have overtime for them, and there's a new regional rate set, and you have the RCN just in front of us. One of the real benefits of the new regional circumstances is that less than full time can now access that, and the proportional uplift for our nursing staff, our administrators and our porters is very similar to the medics. So it's not all just about the surgeon and the anaesthetist. It's everyone doing that additional day of work. And then the third issue, because of the magnitude of our waiting lists, is whatever help we can get from the independent sector, whether that is insourcing, i.e. they come into the trusts and deliver a set of services, or external, they are involved. And some will be familiar with some of those independent sector providers with hips and knees, for example, in the South West Acute Hospital. So that's a sort of summary of what we're trying to do at the minute. But within all of that, there is no doubt, Chair and members of the Health Committee, that we have got to really scale up high quality, efficient practice, and we have got to use all venues. And what I mean is, Joanne mentioned we have a new paediatric surgeon who is readily going to Daisy Hill, one of the best paediatric theatres we have in our jurisdiction, going down there to operate. And the more we can do that, the more we will be using every asset that we have. We expect our patients to travel, and therefore I think it's only right that we as colleagues travel to deliver where we can get the maximum. So that's a short resume, Chair, of where we are. I keep using I'm only 4 weeks into the role line, but it'll wear thin soon.
So in terms of the question I asked about how much is going to paediatrics or how much is going to be spent this year, so I mean in my head, and this might be a really stupid question, but you know, Joanne outlined a number of things that are going to happen within paediatrics, and targets accrued to some of them, and some things that are maybe a bit more difficult, some of them are workforce. So, you know, all of that's going to take money. So with regard to this 215, do we know, is there a plan where the money is being spent? We know how much it's being spent, and do we know how much is going to be spent this year?
Some of the money is in-year money, so it's kind of non-recurrent money, and we're using that for the likes of using the independent sector, doing additional in-house waiting lists and so on. So, you know, that resource is an important resource, but it's always challenging using in-year money to get enough kind of capacity at pace, but we're working very, very hard in relation to that. Some of the money then is actually recurrent money, and we're looking now specifically at where are the gaps in our services long term that we want to fill. We're working with the likes of the training agency NIMTDA at additional trainees, so that we actually have more trainees attached to some of our specialties that are under particular pressure. And we're also then looking at investing in a number of additional staff, some consultants, some middle grade doctors, some nurses, some allied health professionals. So we're beginning to develop those plans as well across all of our specialties. And as you've heard from Joanne and from Paula, you know, while the 215 is not focused on this year in relation to paediatrics, there are some things we will do with it longer term in terms of some of the pressures that we face there. But we have also drawn on other resources available to us to put some of those additional staff in this year and in coming years. So paediatrics is getting some additional investment, but our focus this year is on red flag, which is largely cancer patients, which is I'm sure the committee would understand.
Okay. And I'll just follow through, Chair, that as you know, on the elective care framework, some specific procedures were part of that 50 million. So if we look at 85 million red flag, 80 million core and 50 million new money, that 50 million, one of those procedures listed along with hips, knees, gallbladders was tonsillectomies, and again by nature of tonsillectomy, that's very much a paediatric cohort.
Okay, and I mean, so we had the Royal College of Nursing, and so that was specifically a conversation about issues of workforce problems within nursing. But as I keep saying, every time you meet some section of the health service, workforce is an issue. So I mean, we're hoping to move to a recurrent budget, which could help. But how long is the lead into us seeing differences with regard to workforce specifically likely to take? Or when will, you know, what are you doing, I mean, in terms of recruiting more staff, keep retention of staff, so it has an impact?
I've mentioned the trainees specifically, that we're going to be training more doctors in coming years, sort of through the training programmes that the Medical and Dental Training Agency run. We're also looking then at some additional consultant posts that we actually are putting in place. Some of our challenge, mind you, and it's particularly marked within paediatrics, is that some teams are very small teams. They're relatively small doctors, nurses and allied health professionals, but still a small number of people. A few people go off sick, a few people are absent or indeed retire or move on, and that makes these services vulnerable. Now that's the larger the service, the less vulnerable those can be, but those smaller services, particularly in paediatrics, really do suffer from that. Sorry, Paul, I cut across you.
No, I was just going to say, I mean, there are quite a number of new consultants coming into paediatrics this year. We have 2 new anaesthetists coming in. We also have critical care consultants coming this year as well, and we've been very lucky because these those types of doctors are very difficult to get in the UK and the Republic of Ireland, but we have already secured them for Northern Ireland. Some of the paediatric services are also wider adult services. So ENT, for example, we're currently looking to recruit. There's 4 additional consultants coming into the service, and a 5th hopefully for paediatric services alone. But some of the areas that the 4 other consultants look after, septoplasties and so on, will also be for children as well as adult services. Within paediatric surgery, we have been very lucky, and we have a Northern Ireland trained doctor who's been working in Alderhay, and she's back working with us now. And Mark has explained how much of a change that has helped us achieve in paediatric surgery. We've had 3 new consultants within that service area within the last number of years, and that service is modernising as we move forward. Allergy is an area that's expanding across the whole of the UK, and we're hoping to secure a number of doctors for allergy services. Allergy is an area where everyone wants an allergist. And Northern Ireland, we're very lucky where we can train our own doctors and they want to come home to Northern Ireland. So very lucky to for a number of allergy consultants to start. I'm trying to think of other areas that there are a number of very key people, and we know whenever our consultants are finished training the training course, because often paediatric consultants need to go to the UK or they go to Europe or America or Australia. We have a couple of doctors at the moment, one in Australia and one in New Zealand. When they come home again, what we need to make sure is we have posts, if we have gaps in service there, to bring them home to. And we're very keen to work with our hospitals to do that.
And I think, Chair, your question is really important, because we all know it takes time to train up individuals, whether it be an anaesthetist or a surgeon. And I hope not to keep bringing anecdotal evidence to the committee, but I can tell you that one of the ways we are trying to deal with waiting lists is by using some of our recently retired individuals. And I know a very recently retired paediatric surgeon who was doing many lists in the Southwest Acute Hospital to really tackle the waiting lists from paediatric surgery in that regard. And I could say the same in adult surgery around Omagh, Daisy Hill, Lagan Valley, using some of our just recently retired clinicians who aren't in the night rotas doing the emergencies and doing all the stuff that keep you up during the night, but are very happy to not only be in these centres doing lots of work, but are very happy to train tomorrow's surgeons. And that's one of the areas that I am wanting to focus in on, which is a variability in one's career. When you're at the start of your career, being up during the night and doing all sorts of heroic things is maybe okay. When you get to the end of your career, that's less appealing. So it's looking at not just the infrastructure we have in Northern Ireland and being flexible, conscious that there are 5 trusts, but flexible with how we get people working in different venues, but also looking at how we can maximise activity in the elective sphere, maybe with those coming towards the end of their career.
Seeing that point, because you're talking earlier, you mentioned earlier, patients will be expected to travel, so you would expect the workforce to have to travel. And we all know that in some trust areas things are done differently. In some cases they're done better than in other trusts, and the Minister has prioritised health inequalities. So the last thing the first thing we want to see is our waiting lists reduced, but we want to see that done on a fair and equitable basis. So in your role, first of all, do you, within your role, have the ability to shape services within trust areas so that everybody across the north is getting an equitable treatment? And how do you see, if that is within your remit, how do you see that happening?
Well, I think within my remit, obviously, as a clinician, clinical variation is absolutely part of that, and it's ensuring that every single person in Northern Ireland is exposed to the same high quality service, because that does bring its own health inequalities. So that is why quite often in the past and even now I've said, we need all our hospital infrastructure, but we'll have to do things differently. But doing things differently actually will be a benefit, and the reason for that is, and Chair, we've talked about this before, every winter for as many years as I know, we cancel elective surgery, and we cancelled elective surgery because there was no beds. The pressures, EDs were full, and a bed's a bed. It's maybe for me tomorrow for surgery, but actually it needs to be used tonight for the emergency. And these elective hubs, and we've just had a paper from Southern Ireland very similar to this. We know from NHS England, the surgical hubs separating emergency from elective winter doesn't matter. Winter doesn't matter when you're doing elective surgery. Those beds are protected, and that is one of that's one of many ways I think we will help our local populations who are clearly feeling that it's all drift or loss, but actually know it's gain, so I can look at some of our hospitals today and say with pride, breast surgery's back in, ENT surgery's back in, paediatric surgery's back in, urology's back in. They hadn't been there for maybe a decade, 20 years, but they're back in. That's the kind of approach that I'm very keen on taking forward. And I think, obviously this is all great in theory. We need clinical buy-in. And I think what we're seeing is that old adage, build it and they will come. And I think we have seen already in some of the gynecology services, some of the paediatric services, the surgeons and the anaesthetists from central hospitals going to other hospitals actually really enjoy it because they get to do what they're there to do, and that is treat patients.
And my last question, because we've got the word concern in here with regard to paediatric waiting lists. I think we could probably use a stronger word with regard to our waiting lists in general. They are horrific for anybody that's on them and suffering in pain. So, how are you you're 4 weeks in, how are you intending to measure success? If we are back having this conversation next year, what can we expect you to be saying about how you measure success?
First of all, even the fact that we're quoting statistics that show a reduction in 4-year waits, that's not a success in my opinion, because we shouldn't have 4-year waits. So success for me is, and we are making inroads, but when you look at the paediatric waiting list, 49,877 children waiting for an outpatient appointment and 7,000 waiting for a procedure. That is worrying because you've got children with developmental phases of life that are influenced by this. An adult waiting is unacceptable. A child waiting has another factor at play as well. So success for me is all those doors are open, that we have a recurrent budget that doesn't close any of those doors, and that we have the workforce, and again, workforce, RCN, we're in the room. I'm passionate. This isn't all about doctors. This isn't all about surgeons and anaesthetists. This is about just being really clever with an amazing workforce. Should it be community podiatry? Is there something community podiatry should be doing? Chair, you and I were at the optometrist yesterday. They can do reviews for cataracts. They do review for cataract. That frees up the hospital ophthalmologist to see new patients. So one of the areas that I'm really keen to look at is to be able to sit and look the health committee in the face and say, I know that every hospital at the minute, those new patient slots or those review slots need to be there. And what I mean by that is, if there's an alternative, we should be using that alternative. Because if a dermoscope's done in primary care, but it's repeated again in secondary care, those slots are being duplication. We need that not to happen. We need those secondary care slots for the melanoma, the basal cell carcinoma, whatever it may be. So success for me will be, yes, of course success is going to look at numbers and say, isn't it great, we've now got a further 80,000 reduced, we've now got a further 20% reduction. But clearly, if we're still in the line of talking about 4 to 9 year waits, I don't think we would be proud of that.
And if I might add, Chair, I think some of the things that we're doing is trying to shorten some of those care pathways as well. So directed tonsillectomy, for example, is where we've actually, GPs have treated these children. There's a clear protocol as to when they would require tonsillectomy, and they're able to actually, I suppose, bypass an outpatient appointment and so on and be listed. So I think some of those approaches are required. And there's also something about one way for Northern Ireland. We're trying to think about how can we ensure that clinical variation is minimised. Some of it is warranted because there's different diagnostic access and so on in each of our hospitals. But where it's unwarranted, it's about how can you overcome that variation so that we are maximising our capacity and picking up on Mark's point as well, doing the things in hospitals that we can only do in hospital, doing the things in primary care that we can do in the community readily.
Move on to other members. Colin.
Thank you, Chair, and thank you, Mark, and I wish you well. Not quite at the poacher going gamekeeper, but it's going to be good that you've got both sides of the experience of lobbying for the sector for so many years and now actually being in a place to shape the services, and that is probably the best service. And I'm not sure of the designation of the people beside you, and it's not meant as an insult, but it's often said if it's people that are actually practitioners that are in making the decision about reshaping the service, it's much better because you've been there and you know exactly what it's like. So I hope that will allow to see that change. One of the questions that I will build into is about maybe just how much latitude are you being given to innovate and say, right, here is a service, I can see where there needs to be changes and I want to make those changes. Is that an opportunity that you're getting and that you really can try to reshape the services that are there? Because we do need to do things differently from the perspective of, as you mentioned, a 9-year wait. I mean, that only works for a child if they're under 9, because otherwise they're going to be an adult by the time they get to the end of the 9-year wait. So it's really important that the service is much more agile and responsive to get those times quicker. And also the 3-year budgets, just does that allow innovation for yourself as well? Because the recurring budgets do lend, or the in-year budgets that you get for 1 year and that's it, that lends itself to just throwing it at the independent sector, because you just want to lob as many people as you can off the list and get them sorted this year, and then next year if you're not able to plan, it doesn't allow. So what sort of innovation space are you being given? And if I just give you the second question, so they're both out of the way, is this purely just from yourselves on hospital-based elective type surgery? Because I'm conscious of the waits that people have for things like autism. I mean, we don't even have even ADHD, we don't even have services commissioned, so we probably don't even know how many people there are on those lists, because there's no lists on which to put people. But yet some of the longest waits for where a trust will try and deliver a service, some of the longest waits are in those. So it's the innovation and then just some of those other community-based waiting lists as well.
Colin, great. Nice to see you again. Innovation. Again, it's a great question to ask a surgeon. What controls are on them? I think the joy and the reason I took the job is, and again, it was because of being in the college lobbying and part of Bengoa. I have the utmost faith we collectively can do this. And if we can't, for 1.9 of a population, 1.9 million, it's going to be really difficult for other parts. And I think what we're seeing in England, Scotland, Wales, waiting lists. Yes, we always think, oh gosh, we're the exception. The role at this present time, I've been really pleased to work at SPPG level with Paul as Director of Hospital, with Lisa McWilliams in performance. I report to the Minister and I report to the Perm Sec. Because I came from a department role with the Review of General Surgery, I've kind of been in the department in SPPG, and I still work in the Trust, the Belfast Trust. It's never I, and I think the important thing to say is that it would not be possible for one individual to do this, but I am really encouraged by the number of people that keep saying, look, we've got to do something different and we've got to innovate and we've got to look at different ways of doing it. And I would hope to come back to you, Chair, and Colin, and share what's happening in dermatology in Belfast Trust, the advice and guidance that's already really looked at that horrendous waiting list. AI, where will it fit in? Direct to treatment, all of those innovations. I'm quite excited about it. To date, no one has sanctioned me or put me in the naughty step, and I hope that won't happen. I don't think it will happen. I think we all have a shared ambition. I think everyone around this table has the same ambition as I have. The 3-year budget, absolutely. The more we can have recurrent funding, the less temporary contracts, the less temporary posts, the more we can build the future. And the future, and I know you had a presentation about hospital reform and the hospital network. The more you have that recurrent budget and the more you know what can go into the EOSCs and how we can open up the uncommissioned theatres, all of that is good. And I agree with you, the 3 doors, and I should have said to you, Colin, the best of those doors is the one about our own in-house NHS. The next best is the waiting list. The weakest link is the use of the independent sector, because that's turning off and on a tap. Yeah. We've done that before. So the more we get the recurrent budget, the better that's going to be. And I'm going to hand over to Paul and Paula about the autism.
Yeah, and in terms of autism, and ADHD is in this space as well. I mean, it's not an area that I'm directly involved in, but certainly in talking to colleagues in advance of this meeting, we have unacceptably high autism waiting list in terms of assessment, both for adults and children. 17,000 children waiting for an autism assessment, 4,000 plus adults waiting for an assessment. There's work going on to try and see if we can increase the capacity in relation to it. And there's recently been a project lead appointed within the department to begin to work through some of that, specifically in relation to autism. And we're also looking at a specific needs assessment around ADHD. ADHD doesn't currently have a dedicated service, as I'm sure you know. So there's work to be done there, but certainly those waiting lists are too long. And growing, and I think we are going to have to look at how we will resource that effectively in the future. So it's an important part of the waiting list story, but admittedly other people in the department would be directly involved in some of the work on that.
Okay. Danny?
Thank you, Chair. Thank you very much for that presentation. There's quite a lot in it. I wanted just to start with, Joanne, I think you had went over a couple of the reductions in services. Can I just ask, just with the figures you quoted, the percentage drops that you'd quoted initially, are they broken down, and can you see where people maybe have left the list to go private? People have left the list because they're too frail for a particular procedure, or even died on the list. Sadly, is that, could they be?
We wouldn't have the figures in that kind of detail. So we do validation of lists, including clinical validation of lists, which is a clinical validation obviously is about people continuing to require an outpatient appointment. Mm-hmm. And obviously if you've been a long time on the list, your needs will change. And some people may opt to go private and so on, but some people also, their need will have changed in terms of their kind of where they are in their life. But no, we don't have it in that specific breakdown, and we couldn't have it in many ways because that assumes that people will inform us about kind of going private and so on, for example.
And just to clarify, Danny, and I think we brought it up in the all-party cancer group, those reductions that you're seeing in terms of percentage, 20%, 59,000 episodes of out, those are not the validation, they are actual patient events. So the validation numbers we can certainly get because every trust is doing clinical validation, and I know we talked about it before. Some would look upon validation and say that that's kind of the validation is leading us into a false land, that it's fixing the waiting list but not fixing the waiting list. As I said in the all-party group, the clinical validation is there because of those horrendous waiting lists. We wouldn't need clinical validation if we didn't have those waiting lists, and the reasons are the patient can still no longer have, sadly, the procedure they were on the waiting list for because their health has deteriorated. They no longer need it. So if you've had gallstones and you haven't had an episode in 5 years, and I take you in to do an operation that has a complication rate that you come out of feeling worse, you'll wonder why you had the operation. And the third issue is, quite rightly, that there are people on multiple lists. So if I'm a GP in community and I know my trust has really bad waiting lists, I'll be sending my patients to 3 trusts. So all of that clinical and administrative validation is really important, because can we as a country stand over the banner that says we have the worst waiting lists? Do we have the worst waiting lists and they're this bad, or do we have data that is misinterpreted? And here's the pure data. Here's the genuine picture, and then clearly there are people that will go to the independent sector as well, as you say. So I think clinical validation is really important. It's also important when we're using other centres to do activity, because the clinical validation is not just about do they still need it. It's saying, well, Mark Taylor, you need your gallbladder, but I'm not sure you can have that done in Lagan Valley. I think you're better in a place that's an overnight stay, which is the matter. Or Mark, you will need a critical care unit afterwards, so I think it better be the city. So all that clinical validation is really important to know, and many of your constituents will say to you, I went to this hospital and I was cancelled on the day because I hadn't stopped my medication. They told me I was too unfit for this place, and you know, that's a fail. That's a fail. Especially when we need all facets as possible. So I think the clinical validation is important. The numbers we presented today are hard numbers. And you know, we could certainly provide to the committee by asking each trust to show us your numbers, show us how many were excluded during clinical validation and for whatever reasons, and have that as a set of numbers, and then what we're actually doing, the real delivery of services.
I think it would be very useful for us to see those numbers and to see that split. Certainly what I hear in the community is people who would have never considered going private before are now doing so, spending huge amounts of money from life savings, even borrowing money to go and get procedures that they need and they've been waiting for years. And as you said, people don't just stay the same. They deteriorate on waiting lists. They go, you know, their mobility goes down, their mental health deteriorates, their quality of life falls away. So, you know, people are being forced into getting these operations in the private sector. So they're leaving those lists. But we don't know, as you say, you're not able to say at the minute where, you know, that number is.
And I think
And maybe just to add, I mean, there is an understanding that people are feeling that they must pay in the private sector. That's why the Minister agreed the waiting list reimbursement scheme. So there are opportunities for people to go. I'm sure you have, but I mean, it's notable. I think there is an understanding long waiting lists will lead to people making choices. Everyone will make choices. But I think as much as possible, we are seeing whether or not with something like the waiting list reimbursement scheme, which we've now extended to all of Europe, with the exception of the UK, obviously. That should actually support people to not be paying so much of their life savings towards treatment that they need.
Only half of their life savings.
No, I appreciate it. Well, and I think that's part of the reason we've also opened the scheme up, is because we do appreciate that in some the prices vary in each country across Europe as well.
No, and I appreciate that, and I have constituents who have been asking about it. And it is something that people do look to now as an option. So, you know, I do see there is benefit in that. I think there are issues with it having to pay up front, and a lot of people aren't able to have that large sum up front and readily available.
We have looked at that, and if we can resolve it, we will, but right now we haven't found a way around that.
I would hope that was one question just about the waiting list, just while or the waiting list initiative while you're on it. It's my understanding there's quite a lot of people waiting for cholecystectomies. I think even within the Belfast Trust, around about 1,000 people.
Yeah.
And obviously copied across the whole of Northern Ireland. Is there the possibility of getting that done on the waiting list initiative?
Yes, absolutely, and that's already underway. So there are three parts of that question, Danny, and sorry I'm going to bore you all, but that's my area. One is we do really try to encourage what's called acute cholecystectomy, which is when you come into hospital with a flare-up, that if the facilities are there, that the infrastructure is there to go ahead and take the gallbladder out, okay? So that you're not coming back in and out. That's number one. Number two is all of the trusts have done a big clinical validation exercise on gallbladders, and three, that is one of the additionalities of waiting list work both within Belfast and also the independent sector contract for gallbladders has been awarded to two providers, and their role is to deliver 1,000 gallbladders in the next year.
On the waiting list initiative, is that something that patients can avail of then as well?
Yes, the waiting list initiatives will be in-house additionality, so surgeons coming into Belfast on a Saturday to do a list of gallbladders. So
not the cross-border scheme or anything?
No, not the cross-border scheme.
There's multiple parts to the work we're doing on waiting lists. The reimbursement schemes, one, the waiting list initiatives, and also using some independent sector capacity as well.
Yeah, and that reimbursement scheme, you know, if you need your gallbladder out and you were looking to Southern Ireland or further afield, that is still part of the waiting list reimbursement scheme.
Yeah. It is.
But the difficulty with that is you're paying up front. My principle is that we have many people on those gallbladder waiting lists that don't have the opportunity to do that, and that's why in-house additional activity, and then the use of the independent sector. And it would be important to stress that as a clinician, one of the areas I have to be sure about is that if you can do as clinicians this number at weekends, I would be hoping you're doing that number in your NHS list during the week.
Absolutely. Okay. One other question. It's okay, Chair. The recent NICI reviews of children's waiting times concluded that Northern Ireland's long waits for children are systemic failure, a breach of rights, driven by poor visibility and weak accountability, and the lack of focus on children's services. There does seem to be an issue with data with children's services that NICI have highlighted. How can you measure progress in children's services then if you don't have that data being collected?
We have obviously heavily invested in digital, as you know, from the point of view of patient records. The last 2 years we've seen all of our trusts move to the EPIC system as part of our Encompass programme. So we're hoping that our data will improve, but there's still a lot of work to go on. Much and all, as all trusts now have all of the patient records on. We're still working to actually extract the data from that system because it's relatively new to us as well. But I think data is important, there's no doubt about that. And I think there's also something about trying to, I suppose, understand what's driving some of those waiting lists as well. And I think we've work to do in relation to that. And while I can generally say we know there's workforce issues, I can generally say that we know that there's rising demand and there are some pressures in terms of theatre access and theatre usage and so on. I think we do know that we're going to have a lot more granular understanding of that going forward as well. And we're hoping that information as it comes through Encompass will help us in that as well.
An issue getting data from Encompass?
It's more the performance data, the pulling the data out. It's not a problem at all in terms of clinical use because it's designed for clinical use, let's remember, because it's patient records and it's ensuring that we have all of the patient histories and so on the system. But drawing it out for performance is a secondary use, as they would call it. So we're working through trying to use that as much as we possibly can. And there's some things we'll have to, I suppose, build into it and to allow us to extract more information. But that's happening as we speak.
Been able to get the data?
No, it's not about access data. It's about how you manipulate the data, basically, how you draw it out of the system.
Just to say as well, one of the really good things with Encompass and the Child Health Partnership is set up to, it has a clinical and non-clinical representation from all of the trusts across Northern Ireland, and we're about standardising processes, pathways and systems. So one of the really good things with Encompass is when we put a pathway in place, it's a Northern Ireland pathway. So there are many areas that we're doing that in now at the moment, and that allows us to make sure that our children are managed the same in one hospital to another. They're counted the same way, and eventually it will allow us to look at a totality of a waiting list as being the same thing. So you'll be able to look at all children who are waiting for a particular procedure, regardless of where they are, how long they wait, and it'll be able to be standardised in that way. The fact that the clinicians are able to put standardised pathways in place and agree that actually is a real massive benefit of Encompass as well. Real massive, because we've never had that in Northern Ireland before, and there is actually a CAG, a clinical advisory group, to do that. So it's quite exciting for us at the moment that we're able to do that.
Encompass opens out that regional list that you'll be able to see every child everywhere on every list. No, that's fantastic. Thank you.
Okay. I think, Danny, there's also the opportunity to come down to SPPG, actually to the performance group under Lisa, because it's amazing. I've certainly had my eyes open to just how much data there is there, and obviously the waiting list management group is there, but there is a massive amount of data, and that's certainly one area that I will be using in terms of variance of practice.
Yeah. Linda?
My first is a point. I don't want an answer. I want us to take away and find a solution, because I think that there is a solution. The 2 year waiting time should be scrapped. It's a nonsense, because asking people to be 2 years, that's not taking into account how urgently they need their surgery. Does that mean in that period of having to wait that because of their health problem, they lose their job. They couldn't pay for it by the time they're able to actually avail of it because they're not working, because they've lost
This
their
waiting
job.
list reimbursement scheme, it's down to a
reimbursement.
year. We reduced it about 2 or 3
I know you
weeks ago.
did. I would scrap it
Yeah.
altogether.
Well, I suppose
I'm just saying what
I
I would
understand
do.
the point. Sorry, I
think-
thought it was the 2 years that
Sorry.
was the issue. Apologies.
And I think that we need to seriously go away and look at that.
Okay.
What is the value of having you waiting a year when you could have your surgery, be back at your work? I have a number of examples of people who are carers, and I don't mean just caring for family members, people who are actually working in the health service as nurses and carers who are having to leave their jobs but they could avail of the reimbursement scheme, but they're unable to. So I'm just making that point.
Before you ask your question, just on that point, because I actually had a constituent the other day who, because it was 2 years, went and paid for the operation privately, and now it's been reduced to 1 year, and they have lost out because they would have been on it 1 year. So there's a cohort of patients now who will be feeling rightly very hard done by because of that.
We only had a certain amount of money for the scheme. We put it out at 2 years, and we're hoping that would actually draw in enough people. But there wasn't enough people coming forward. Therefore, we had the opportunity to reduce to 1 year, and also then to actually make it EU wide. So it's as much of it was to do with the resource that we had available to us.
I told the minister when the 2 years was announced, I said, you will not be able to spend that money. Remove the 2 years. Why are you doing that? This is a nonsense. So I'm just making the point. Take it back to him. Solution focused. Scrap it. Let's get people off these waiting lists. Let's allow people to go back to their work and get on with their lives. And people who are almost maybe at the end of their lives, just like a wee bit of quality for whatever period they have left. They don't necessarily have a year or 2 years. Just on and I'm really, really happy to see the reduction in those waiting on PEG surgery. I have to say that is something that is to be commended. It again, costing our health service a fortune, and nursing hours, nurses having to go out to those children who do not now have to go out to them because they're being PEG fed, taken away, horrendous circumstances for families. So a well done on that, I'm going to say.
What's even better is we now have a regional pathway across Northern Ireland that allows children to be held locally as long as possible, and they only actually need to get into Children's Hospital to get the surgery done and then back out again. And every single one of them children, every week, is considered whether they're still on that list. And I mean, we had 4 children last week cancelled who had surgery this week and next week, and they were cancelled for other reasons, and that's what happens with children. So having that really fresh waiting list and proper processes and systems in order to do that is exactly what we need for all of our services. So you're right, it's been an amazing thing that the doctors have managed to do.
And that is a good news story, because I do understand it is a very and when you're dealing with PEG surgery, you're talking about complex cases. Nothing is straightforward with those surgeries, so I know it is very difficult to do that. So I do think it is worth saying that, you know, when things have been done well, we need to acknowledge that. So just then, you talked about time critical, and I understand when the chair's question around the money, and you can't say because the red flag are the ones on the time critical. But what constitutes time critical? Because we have said about children who maybe get to a point where the surgery is no longer viable because it's not going to make the difference that it should have made, or it's actually just not possible at all. And so is time critical just where that person might die, or is it time critical where a child must have a surgery before they're 6, before they get to a certain stage of their development? Is that considered time critical?
Well, that's the discussions we're having as part of the surgical group on the Child Health Partnership, because what we want to be able to do, and obviously we need to have that in medicine too, there's not a clear definition of what time critical is, and we are almost making this up as we go along. I mean, life limited is kind of how we term. Now, that's different for a child because it's about a developmental thing as well. So you can actually limit a child's potential. You can limit their what they can do. You can limit what their developmental scoring. So what we plan to do as part of the Child Health Partnership is consider all of our services and where the needs are. And that's what we're doing at the moment. We're looking at baseline services to look at where we see our gaps in a Northern Ireland population against what would occur in other areas and how we can fix them. And some of them will be waiting list issues and some of them will be on schedule care at your front door. you know.
You get a written briefing whenever you've completed that and you have an assessment of that. So I'm not asking you to come back in and present, but I just would like to understand, because I've had a number of cases where I would consider them absolutely time critical, because some of them were about getting children on their feet, and if they're not got on their feet by a certain point, muscle wastage and everything, that child's never going to be on their feet.
I would agree, Linda, and I think time critical, certainly from our paediatric ENT work, and I know again, it's champions that are helping to do this, but you know, time critical depending on the paediatric specialty. So for me, adenoids and glue ear are time critical because they're developmentally delaying speech and hearing. I know we live in the world where time critical often links to cancer or something like that, but in PEDS, that's why I said at the start it's a different area, because it's not just the prognosis, it's actually the developmental impacts, and that's where some of our ENT champions have been very focused in on, you know, the neonate or the 3 or 4 year old that isn't speaking or isn't seems not to be hearing. All of those things, that's as big a priority as some other more prognostic impacting paediatric specialties.
No, that is good to hear, and as I say, if we get a written briefing just so that we get an understanding of that, Chair, that's my other questions have already been answered, but thank you.
Thanks, Linda. Al?
Thanks, Chair. Good that there is some positive news buried within the report that we were provided. That is, we'll bank that. This room in here is known in some circles upstairs as the room of doom, and they get a bit of positive news. That's a good day for us. Can I just ask on the PEG surgery? One of the criticisms that I had faced and heard at that time in which we were at its peak was the lack of communication for families. I suppose we could broaden that out to wider waiting lists. So, for example, somebody on a waiting list for X amount of years, how are they updated? What is the process? How many times, how frequently are they updated? And I suppose, given we have a waiting list reimbursement scheme now, you know, somebody who originally was told that they were maybe on for 6 years, there are people being pulled off that 6-year waiting list who are successfully applying to the waiting list reimbursement scheme. So what is the process there for someone who has originally been told 6 years?
I'll maybe kick off. GPs will ask these questions as well, because GPs will say, you know, we need to be kept apprised of the progress of our patients that we referred onto the waiting list as well. So I think it is a challenging issue. And obviously, as waiting lists are long, it is important that patients are communicated with. I think that some of the issues around just the numbers on the waiting list obviously makes it challenging to keep people apprised of progress in relation to the waiting list. I think we have to accept that. It's not the right thing, but I think that's part of the challenge of the communication. We would like to hope that Encompass might also help us with that, in terms of having some ways of contacting people through the automation of the system as well. But I don't think automation is necessarily the answer in all of these things either. But it is a challenging issue. There's no doubt that it's a challenging issue. And given where our waiting lists are at this stage, you can imagine that patients are going back to their GPs regularly, asking their GPs what exactly is happening. GPs then are making requests. It would be much better if we were proactive. And actually giving people an update as we go along. Now, I think it's something that we have to look at, but it's work that we've yet to do.
Could I also draw attention just to one of the things that we've committed to in the elected care framework is the development of a waiting well policy and scheme, and that's about working with our trust, working with community and voluntary sector organisations to support patients while they are on our waiting list, and that can be about providing them with advice or directing them to local services that can support them for their particular condition or need while they wait for surgery.
Chair, I was going to come in on the waiting well policy as well, Alan. I think it's a really important question. The waiting well policy has many aspects to it, not just the when am I getting my operation, when am I getting seen, but also strategies that we can use to keep you well during the time you're waiting. And that is particularly in musculoskeletal. So what can you do to keep your muscle bulk there? I think Linda mentioned per muscle bulk at one stage. In my world, enhanced prehabilitation before any major surgery is an absolute must. There's ways that what we can do, and whether we use our social or our community or groups like Versus Arthritis to work with us to say, yes, we know that individual is going to be on a waiting list, but here are things we would like them to be doing while they wait. The exercises, the going to the swimming pool, whatever it may be in whatever specific area. There's also a comms piece that we are currently working on, and you'll have seen even this week, or it's coming out this week, a little video on the waiting list reimbursement scheme. A very simple video to be pushed out to all GPs, pushed out to all social media platforms to try and encourage as much uptake
no
as
waiting
possible.
time. That would be great.
We might have to edit it.
Obviously, Mark, there is an understandable frustration and a lot of pressure then within the system whenever you have patients frequently, monthly, annually, ringing up their GP or others asking for updates. So if there is something proactive that can be done in that regard, then that can only be a positive.
I can say too, around the peg tubes, I think was a real learning thing for Children's Hospital and for services, because I don't know if you know or not, but as part of the whole work of the peg tubes, and when we were working with the parents, we designed a leaflet that went out, and it was an update leaflet that went out to parents who had children who were waiting on their peg tube surgery, and then they received that every month or 2 months whenever there was changes. And actually I think that is a really good way where you could have a support group like that. So when you have a distinct set of parents or a distinct set of, that is something we can learn from in other areas, because that kept everybody up to date. And I think it also was shared with some of the MLIs that had shown interest or whatever in peg tubes as well. I think that helped parents understand how many, and they could see waiting lists coming down. And there's always reasons why people maybe wait a wee bit longer, maybe for diagnostic tests or whatever, and that explained things like that within the leaflet. So it informed as people about the pathways, it informed about the diagnosis and so on, and we had lots of positive feedback about that. So it might be something we can learn from in other areas as well.
And I suppose, Alan, just to add to that, part of the reset plan, the committees in common, and if I had the magic bullet, it would be wonderful, I think, if we all had, which is the scaling up best practice. So it's when we have learnt in one particular area how to improve the communication, how to have people not... some people challenge to say, why are we fixing waiting lists? Well, the waiting lists permeate into unscheduled care, into primary care, into social care, into every care, repeated admissions, repeated phoning your GP. As a clinician, I get GP letters every week saying, this lady's still suffering, where is she in the waiting list? Can you bring her up the waiting list? What can we do? All of that is the reason why we've got to start somewhere, but fixing or doing as much as we can on the waiting list will reap the benefits. But scaling up that best practice, the committees in common, meeting together and under the reset banner, if we're seeing areas of good practice, long gone are the days where we can say, well, that's done in the West, we don't do it in the North. That's done in Altnagalvin, we don't do it in the Royal. Those days have to be finished, and it has to be, we scale up the best practice for all of the citizens of Northern Ireland.
Can I ask just one short related question, Mark? Obviously your role as Director of Elective Care, we've frequently been told about a vision for Causeway Hospital and it being a elective care hub. Have you had any discussions around that?
Yeah,
You have?
Absolutely,
Okay.
Alan. I'm happy to take it offline with you. As I have said, and please, I hope people don't think I'm a false prophet, we need all the infrastructure going, and actually the jewels in our crown will be our rural hospitals.
Every square inch, as the Minister said.
Because they run, I'm coming to Causeway soon, because the anaesthetists there have a wonderful perioperative pathway. The clinicians want more work. in Causeway, in the operating theatres, and a bit like Southwest Acute, Daisy Hill. There's nothing attrition about what we're planning to do in Causeway. It's the opposite. And we need all that infrastructure. And again, the data is there. We know that there are unused activity, and we need all that activity to be used. So if there's not theatres open for whatever reason, the work isn't there, the anaesthetic rota isn't working, we need that all rectified. So I look forward to coming down to Causeway. I've been a few times recently. For me, whilst I know there's a lot of anxiety in the community about the loss of something, I'm more interested in the gain. And if you have lots of surgeons in that building, then all the other arguments are somewhat academic.
And Dodge told me good things about you, so you're speaking the right language. Thank you, Mark.
Okay, Linda, you were looking back in again?
Only on a quick point that I didn't raise, because obviously we're here on paediatric waiting lists, but I would like to understand or get an understanding of where Gainey sits within this tackling waiting list, because everything else is popular to talk about. Nobody wants to talk about Gainey, about endometriosis, about prolapse, about all of the challenges that so many women are facing out there.
I can assure you, Linda, the Minister does at 4 o'clock.
Okay. Is that what,
there are plans for Gynae.
Yeah.
Linda, just to say to you, there are big plans for Gynae, and we have started.
tell me, can you give us all the plans and answers on I can't remember if it's Monday or Tuesday right now, because I'm losing days of the week.
Some of the challenges in Gynae is also related to obstetrics. So it's trying to balance between the elective work in Gynae versus some of the, obviously, the unscheduled care work in relation to obstetrics. So there are challenges there. But there's a lot of work going on to try and, one, reduce the waiting list within Gynae. That's key, definitely. But also looking at some of those issues within Gynae, some of those services like endometriosis, like sort of a range of services. And work is ongoing, and it's part of the space.
Back to diagnosis, because the delay in diagnosis is the biggest issue actually for women and girls. So we're saying this about paediatrics. There's girls who are suffering with this from their 10, 11 years of age, but they're not diagnosed till they're in their 20s.
And the first provider collaborative has all been around gynecology for that reason.
And also we have an amazing GP enhanced gynae service as well, and it's getting up to full operation as well. So gynae's an area where modernisation is key, and also, the use of specialist nurses in gynae is something that we're really pushing as well. So
maybe get something specifically around this in the Women's Health Action Plan.
Well, I mean, I was going to say, Mark, and all of you is like you're only in your post 4 weeks. So, I mean, reducing waiting lists is one of the key priorities of every citizen across the north. Hence, it's in the programme for government. Hence, it's a key priority of this committee. So, I would be expecting you would be regularly in front of the committee to discuss overall waiting lists and reductions and how this plan is going to be taken forward. And I'm conscious that you're 15 minutes. We've kept you 15 minutes late.
Oh no, don't worry. Can I keep saying I'm only 4 weeks into it?
The honeymoon period is over. The room of doom, as I'd never heard it described like that before. But yeah, no, but I mean it is. I mean, everybody here wishes everybody involved in this success because it's too important that we don't get right. So. Good luck with that. So I'm happy enough then. Appreciate you coming.
Thank you.
Thank you very much.
Okay, members. So, I mean, I'm just noting here from my notes. So, waiting list is a key priority for the committee, and further briefings have been scheduled and will be scheduled. So, I mean, I'm actually going to suggest that we take a wee 5-minute break, just if people want to go to the toilet, stand up before we take the next thing, if we're happy enough with that. Good.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29, 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 Sound. Committee.
Can I ask just with that?
We online? Yeah, okay, we'll just...
In reference to that briefing we've just had,
Yep.
could we write and ask just for those figures, just on the,
Yep.
I think it was the...
From all trusts, so the
Yes,
figures...
Waiting lists from each trust to break down how many people were refused or couldn't get their surgery for whatever reason.
are wiped off because they've maybe had it.
The full revalidation
Yes.
with all the reasons on it.
Yep.
So that we can understand just how those figures make sense.
Absolutely. I think that is good for us, but it's good for the public to see those figures as well. Okay, so moving on then, item number 7, oral briefing from the department, IT issues in the Southern Trust. Can I refer members to our papers at tab 7, page 161 of the main pack, and to the papers issued by the Southern Trust in advance of the meeting. So can I welcome Dr. Paul Rice, Chief Digital Information Officer from the Department of Health, by video link, it's saying here. Okay. Steve Sporey, Interim Chief Executive, Dr. Steve Austin, Medical Director, and Elaine Wilson, Director of Planning. You're all very welcome. Okay, well, so Dr. Rice, can I just check you can both see and hear us?
I'll say no.
We can't hear you. Give a thumbs up if you can hear us. Yes. So whenever you need to speak, we will inform broadcasting who'll let you in. Okay. So I hope maybe he's given the opening remarks. I don't know. So we've received presentation. So if you want to add to that, and then we'll go straight to questions and answers.
Yes, absolutely. Do I need to do anything with the microphone?
No, just speak.
Okay. So,
as good as you can.
So, hello. As you've said, I'm Steve Sporey. I'm the Chief Executive of Southern Trust. I've been in post for about 6 months. This is my first appearance in front of the committee, although I've met a couple of you at least online or in other settings. I'll say something just by way of an introduction, but then we were expecting to go straight into questions, Chair, if that's okay. So I think, as you know, last Wednesday morning, the Trust received experienced a full outage of its electronic patient record system in Compass. And that caused a serious disruption to services throughout that day. I personally was on holiday, so I was getting WhatsApp messages about it, but I was in a mountain in the south of Spain, so I wasn't terribly accessible. During the course of that day, a lot of our colleagues, of course, the great majority of our colleagues experienced disruption to their working lives because they couldn't use systems. And I'm afraid to say something just over 1,600 patients missed appointments of one kind or another because we stood down clinical activity. And of course, people attending the emergency departments waited longer than they otherwise would have done. So I'd like to take this opportunity to apologise to those people who were adversely affected in that way. I'd also like to take this opportunity to thank our staff, and it was a myriad number of staff who worked calmly to preserve the services that we could preserve and to be ready to scale up again, as I'm pleased to say that the full electronic patient record system was restored on the Thursday. In particular, I got a strong sense personally that it was a well-controlled response. That there is an escalation, a business continuity response process. So it's one of the things you have to plan for is the potential partial or total loss of your electronic systems. So I'd also like to say thank you to some members of this committee and other public representatives who were in touch and who communicated with the public during the course of that day as well. We're very sorry about what has happened. I'm sure you'll want to ask us about it. Our response in a way is threefold. There's an investigation into what caused the technical problem in the first place. And after we've ascertained the cause, what do we need to do to prevent a recurrence? There's the process of rebooking those patients who missed their appointments and making sure that they're seen again as quickly as possible. And then there will be a process of looking at how our business continuity processes worked. So how well did we do? You know, there's always, in my experience, some learning from these kinds of things that we'll have to make the most of. But I think, Chair, that's all I'd like to say about my initial comments.
No bother. I appreciate that. And as I say, we have received written. So from our point of view, I suppose, again, there's three issues. There's one, the issue of the IT within the Trust, and then there's the issue of the patients within the Trust, and then there's probably another issue of other trusts and potential resilience within the system. So I'm going to declare straight off the bat IT is way above my levels of knowledge, so some of these questions might seem ridiculously stupid, but I just want to get a sense. It's not the first time I will have asked stupid questions. So in terms of the IT, I mean, are they in buildings at the hospitals, or are they separate buildings?
I think what we'll do, if you're all right, if Elaine answers that question initially, and then Paul might want to come in as well. Okay. So on top of that question, I just want, like, who is it? The Trust themselves that looks after the IT, or is it outside bodies?
Yeah. So we have 3 data centres in the Southern Trust, 2 on the Craigavon Hospital site on different locations in the site, so they're not together, and then 1 on the Daisy Hill Hospital site. The 2 that are our 2 main ones that went down were both the ones on the Craigavon Hospital site, but not because they were physically located close to each other. They are on different parts of that site. And we have a private sector provider that supports all of the maintenance of our databases. So the Trust do not do any maintenance to them. They don't change anything on them. That is completely and utterly maintained by a network provider.
Okay. And I mean, we obviously had questions to the Minister the other day. He indicated that it was as a result. So I'm a bit confused because we're saying, we're being told that it'll take a number of weeks before we know what's happened, but yet we're already ruling out things that, no, we're being told it's not this and it's not that, but we don't really know what it is. And the Minister seemed to indicate that the fault occurred as a result of a planned upgrade. So again, with the lack of knowledge that I have with IT, it seems strange that you're being told we need 3 weeks to find out what happened, but we can tell you it wasn't for anything from outside, and the Minister's saying it was an upgrade.
Can I start on that, and then Elaine and Paul may want to come in. So I think when you're looking at something like this, you start off with key lines of inquiry, basically. You think you might know, and there had been a process of upgrades. So that was an obvious place to start looking, and that remains the key line of inquiry. Okay. So in that sense, the Minister's correct. That's where we looked first. If we began to find we didn't think that was the problem, we'd look at other possible causes. But it was the obvious place to start. And I think it's also important to say that when you're saying the cause of the problem, it could be the upgrade. There's a number of ways in which that could have caused a problem. Like it could be a fault in the software that we weren't installing, that was being installed for us. It could be a mistake in the way in which it was installed. It could be something wrong with the hardware, for instance. Do you see what I mean? So even if you said it was the upgrade, definitely, you then have to say, so what more specifically was the cause of the problem? But I don't know if Elaine or Paul wants to add to that.
Yeah, I mean, I suppose these are very, very complex systems. It is normal in this sort of thing for it to take a number of weeks to get into exactly what has caused it. So while that piece of work has absolutely started, and we started it as quickly as we could, it is extremely complex, and our providers have to go through logs, and they have to go through logs leading up to the event for a number of days, as well as the day itself, to try and work out what was happening before and what was happening on the day, to get themselves to the point where they start to, I suppose, follow a very definite line of inquiry. And then it takes time to get from the definite line of inquiry into the actual, we're really sure this is what happened, and that just does take time. And I'm sure Paul will come in terms of, we're taking advice from our specialist colleagues in the BSO in relation to how long these things normally take, and they're saying that sort of that 2 to 3 weeks. But because at the minute this is so complex, we just don't know exactly how long, and what we don't want to do is guess what happened, or suggest things happened that didn't. So I know it's probably frustrating that we're not telling you that we know definitely what happened, but until we know definitely what happened, we don't want to be suggesting what that might be.
How can you rule things out then if you definitely don't know what happened?
Well, I suppose what our providers of our network support are saying to us, it was not a cyber attack. We know that, and they've ruled that out. And we will just have to wait and see. The other thing I'll say, just to be really clear, this was a connection problem into the regional data centre, so Epic and Encompass were working perfectly well for the rest of the region. We actually lost connection to everything, so it was our Encompass patient record, it was our NIPAC system and our LIMS system for our labs and our radiology. So it was definitely the Southern Trust cut off from the rest of a network that was working.
And I'm just going to fire questions at you. So is the provider for the Southern Trust different than the provider in other trusts? And secondly, in terms of the cost, do we know how much the breakdown is cost, investigations cost, put and right cost, and who covers that cost?
So we don't have a cost for how much the breakdown has cost or the recovery yet. In terms of the supplier, it's not the same supplier across all of the trusts and the health service, but it is this. We are not the only ones who have this supplier. There are other parts of the health service in Northern Ireland have the same provider.
In terms of cost, it has cost. It will cost a bit of money, to be honest. When we know the cause of the problem, we'll look and see what sort of contractual recourse we've got, if that is appropriate. But we need to we need to go through the process of understanding properly the cause, and I can see Paul wants to come in as well.
Okay, Paul. In broadcasting, let Paul in, please. There we go.
Yes, I just wanted to return to the slightly to the previous question about how can we roll out things. So, I mean, Elaine's covered that adequately, but for example, there are other ways and measures in which you would identify an external threat, a cyber threat, and in reality, we know that that has not been the case. So the way the Minister is able to rule things out, Chair, is that there are other warning mechanisms, there are other systems that are wrapped around our systems to specifically address those sorts of risks. None of those systems were triggered. None of those systems were. There were no indicators in relation to those systems. So as Steve has said, we've started therefore, the Trust has started therefore at the most logical level of what work are we undertaking which could have created this problem. So that's why the Minister's statements are accurate in that regard.
And Paul, just want to have you on, because I'll go back to the Trust in terms of patients in a second, but when you're on, so this is one trust, but we have a number of health trusts. I mean, how can you give reassurance to the committee and for us, to the public, in terms of the resilience of our IT systems right across all the trusts, and that, you know, we're not expecting an issue like this? Because, I mean, as I said the day of questioning the Minister, you know, we all get upgrades in things, electronic devices regularly, so I would expect within health trusts upgrades are regular. So, these are things that we can't afford in an already creaking health service that cause added disruption. So, I mean, we're just looking for reassurance from you in terms of the IT systems right across the rest of the trust.
I mean, I think it's important for me to be clear and candid with the committee that the reality is that incidents will continue to occur. It's a question of the way in which we manage to reduce the likelihood of those incidences. As Elaine's outlined and Steve's outlined, these are a complex interrelationship between people, processes and technology. They often, as in this case, involve representatives of the Trust working in conjunction with representatives of commercial third parties. It would be, I think it would be unhelpful for me to give the committee an unqualified assurance that an incident of this nature will never happen again. However, I think the nature of the root cause analysis work that's been undertaken and the wider review will allow us to have learning points which we will not just be using in the conjunction with colleagues in the Southern Trust, but which will be used by the community of Trust and IT leads across the whole of the province. So again, Chair, I think it is important that we all collectively recognise that it's a nature of modern life that technology is central, and that there will be occasionally incidences where it lets us down, or where it, in conjunction with the people who manage it and the processes we wrap around it, don't work to an ideal level. But as the Trust has outlined, we're taking every opportunity here with a quality of independence to learn those lessons, and then we will distribute, proselytise, communicate those lessons, use workshops, use a whole range of methods and models to make sure that that learning is distributed across the province to reduce the likelihood.
So, I mean, one of the obvious concerns to everybody when this was reported was the news that the backup system had went down. So, I mean, that really defies its name, because you expect when a system goes down, the backup system there works. So, I mean, can we have a greater explanation of just exactly why that was not the case in this, and if there's going to be lessons learned beyond this particular trust with regard to backup systems moving forward?
Chair, you address that to me again.
Well, I'm going to address it to you first, and then I'm going to ask Elaine to come in afterwards.
I mean, I have to say, I'm afraid my comment will be consistent with what Elaine said about trusting our current process in relation to that root cause analysis. You're absolutely right. The clues in the title. A backup system is there to provide an alternative when the primary system doesn't work as the way that you intended. We need to understand why, both in this context, the primary and the backup systems didn't work to best effect. So I think in the outcome of the root cause analysis work that's going on now with the technical element of this should identify exactly what went on with relation to the primary and the backup systems.
Liam, do you want to add to that?
Yeah, I mean, I suppose all I would say is this is certainly not expected. We would not have expected both of our data centres to go down at the same time. They regularly, we would take one down to do some maintenance or take the other one down to do maintenance, and they do that very successfully and always have done. Something very strange has happened on Wednesday morning to take them both down together, and that's why we do want to get in underneath this root cause analysis and do that in a very open and transparent way. I mean, we've set this root cause analysis group up. We have technical experts from the other trusts on it. We have people from the BSO and from the DHCNI as well as our own trust people, just so that we have got that check and challenge that we're really going to get in underneath what happened, because it shouldn't have happened. But because we don't know exactly what happened, we don't know how to prevent it.
And just the last question on this, I mean, once this information is with the trust, will the information be made, will the rest of us get to hear exactly the root causes of this and the costs of it, and et cetera, et cetera?
I think we would be happy to make a public statement when we know the definitive answer, but I don't want to be bounced into saying something. I mean, you question about why didn't the backup work is exactly the question we're asking ourselves. That's the real key. I was in Spain thinking what's happened to the backup at the time. It's exactly the right question, and we will go public on that when we know about it.
Okay, thank you. So just moving then on to patients. So there were 1,600 patients affected in the presentation, so we only got that this morning. So I would like to have a bit more, but quicker, just to go through it in detail. But 72% of it have been contacted in terms of rescheduling. 72% have been rescheduled.
Yes,
is that correct?
Yes.
Everybody has been contacted?
Yes, and we're now, as of today, up to 80%.
Okay.
So we are getting people rebooked in as quickly as we can.
Okay, and I mean, obviously, you've apologised for the impact this has on patients, and we want to ensure, first of all, that we get our IT system back up and running and being resilient, but we want to get sure that the patients who had very important for them appointments rescheduled. Red flag. So, I mean, can you just outline just how much of a priority it is to deal with red flag and high priority patients?
I think that's best answered by Stephen, Dr. Austin.
So, and thanks for asking that. Like, those are very much in our mind about the clinical prioritisation of the patients who had their appointments postponed. So we have been getting some clinical oversight of that to make sure that the consultants and those who are looking after those patients are able to pick out the ones they think absolutely need to be done earlier rather than just in sequence. It'd be better to make sure that the ones that need, in this case, a red flag or say cancer therapies, that's done as soon as possible. But I can tell you that the red flag patients, I think we've got less than 5 patients out of are the ones we've got, and we have over 100 who have cancer. They're all been, that means over 100 have actually had appointments already scheduled. 2 or 3 were being sorted out today, so then the last few of those getting sorted out. They're in place, those new appointments. And the other patients we have, as I say, it's about 80% are now rescheduled, and we're just going through the final groups of those. But the ones with more clinical priority have already been broadly rescheduled, so we're working through that. It's only been, of course, last week we got access to the data really on Thursday, Friday, and we've picked up the information of those patients. They've all been contacted, and there's a sort of robust process to make sure there's clinical oversight, to make sure they're done in the correct sequence. So we'd want to minimise any impact on patients, obviously, and preserve safety and quality of care.
So in your written briefing, you're saying everybody within the red flag sphere will have their appointment by the 30th of October and everybody else by the 13th of November?
That's the current figures and the ones we've booked already to date. So, but the red flag, certainly the information we had, there's a small handful left to be done this morning, and they were being sorted out today. So
some could be beyond the 30th of October deadline.
Can I just be a bit more precise? One category of patients will, we think, go beyond the 13th of October deadline. That's routine reviews. Patients, so everybody who's a first appointment of any kind and everybody who's an urgent or a red flag review will be done by that date. Yes. That's what we're aiming at. Routine reviews who might be coming back once every 2 years or whatever, As of last night, the latest was the 21st of January next year that we'd been pushed out to. But that's using the clinical prioritisation that Stephen was describing too. But I don't want you to be misled and think we're promising to do everybody by date in October when there's one category. Some of them.
And just in terms then of the patients, so I mean, we're talking about the 1,600 patients who were scheduled for those couple of days. Is that likely to knock other patients then who are in need of urgent treatment?
What we've done, and I checked again this morning, is that the patients have been rescheduled, have been put into some capacity that have become available within the system, and then we've put on some additional clinics, operating sessions, and so forth to try and get those patients. So no patient has been bumped as such, okay, or postponed. Patients are already in the got their, over the next week they haven't been asked to move an appointment.
So it's additional capacity.
It's additional or unused capacity that we've found. We've managed to optimise that.
Okay. Thank you. Linda?
You've literally just asked every question that no, here I'm not complaining. It's good, because that was actually my main concern, was that we would forget in the middle of all this the people who may be knocked back because of the people whose appointments were being met. So that was done through additional capacity, and capacity that became available. Will there be some knock-on effect? And if so, if you can't give us an idea of that right now, will that be included in the review?
We don't expect any knock-on, because I think we're trying to get some additional capacity for the ones that are left. But as I said, we've got 80% patients that we've booked already, so the final 20%, where there'll be additional clinics, we'll try and get those done in a timely manner over the next number of weeks.
And was the Trust given additional funding to help them with that by the department? Or did you have to find that within your own budget?
The department, the SPPGA within the department has allowed us to use some of the waiting list initiative monies if that's appropriate, but mostly we've managed to do it within our own available slots in our clinics.
So what we're doing is we're looking at the position at the end of every day, the following day, so we're clocking down that 1,632. You see what I mean? So the position you've got was, I suspect, at the end of yesterday. We'll look again at the end of today. Until we're sure that they're all played out.
Do you think then, this is my last question, just given that we've been able to, and I appreciate 1,600 appointments actually isn't massive, it's massive for all the people who it impacted, but in the grand scheme of things, so if you spread that out amongst every single service that's provided in the Southern Trust, I know that there wouldn't be maybe a massive number in each service. But do you think there will be learning when you do this review of how you've been able to accommodate those 1,600 and the work that has been put in place? And you talked about the robust systems that have been put in place. Do you think there's potentially learning here for how we make best use of appointments going forward?
Well, you can always do things better. I think one of the things when we do our review of the way the Trust has responded, one of those things we'll get information from that, we'll feed into our general. You're asking really, does that affect normal processes to make it more efficient? Yeah. Like we can always learning from any source and use that to improve the service. Absolutely, we'll take.
And will we get that information as well as part of the?
Well, it's one of those. If there's things we find opportunities that might take a bit longer to put into operation, but certainly if there's learning, whenever we get the the opportunities to share some of that learning, like we're quite happy to explain.
I think that would be good, because if there has been an opportunity to say, here's how we did something slightly differently and it really worked. Also maybe an opportunity to show SPPG that sometimes being very dynamic is a good thing. And just because this is what we've always done, this is how we should continue to fund it and do it, isn't always the right answer for Trust. So I think that there sometimes in the worst case scenarios there can be opportunities. So that's why I'm saying we would like that information, because let's use it to hold the department and SPPG and others to account, to show that sometimes things can be done really well, really quickly, and we should take the learning from that. I think we learned so much during COVID, and an awful lot of it. I'm always afraid to mention that because nobody wants to be reminded. But such a slide back in so many different areas, not just in the health system, right across the board. So I would just like that we have a better attitude to learning from emergency situations. Good things can come from it as well.
No, I couldn't agree more. I think maybe just to mention that we didn't know what caused this. It was an unusual situation, but the staff reacted. Our clinical staff, nurses, doctors, physiotherapists, HPs reacted in a very positive, dynamic way to the situation they found themselves in, they were adaptive, innovative, sorting it out, and were able to protect patient care over those few days, and then step back up again. And that's all been taking place within a relatively short period of time. So the staff have been wonderful doing that, and we've had support from from our colleagues across the region as well. So I think that's one of the things, that our staff are fantastic, and is a great resource for us.
No, I think it is a good opportunity, Chair, actually, to commend the staff. I spoke to a number of them over at the hospital on that day, and you're right, their attitude to we have to get on with it and do what we can in the way that we can do it was excellent. I mean, they just got on with their work. Everybody else outside might have been panicking, but they were just doing their work.
Just to emphasise, the other part of learning is how did we handle the incident on the day.
In the future.
So as part of the incident management process, when you have a real incident, you have to do a review afterwards. We had our board meeting this morning. They were receiving the same information the committee has received. Of course, the board were very concerned to make sure that we did the proper technical investigation into the cause of the problem. They want to know that the review of the incident response will be carried out thoroughly, and expect a report. And that's the role of a board in these circumstances. So I'd emphasise that. Anecdotally, we're already hearing things. Just to illustrate, some areas suffered with problems with Wi-Fi access when they were trying to use WhatsApp to communicate. So we'll need to take that into account. And on a lighter note, one department couldn't find enough pens because they've adopted the electronic communication so much when they had to go back to pens and paper. It was a case of where's the pen.
Sometimes the simple things.
But that kind of thing matters.
Thank you, Chair. Thank you very much.
Thanks, Linda. Al?
Thanks, Chair. Forgive me if I missed the answer to this in the public pronouncements and maybe some of the paperwork that we got very late. It says in bullet point 2 that despite every effort, the network infrastructure support provider was unable to resolve the issue. So if the infrastructure support provider was unable to resolve this issue, who did resolve it? Was it external assistance that was required? And are you confident then, as a result of external assistance, if that's what it was, that there was no loss of sensitive patient data or staff data?
So I suppose it's the phraseology maybe in the paper. What we were saying there was they weren't able to resolve it very quickly, and that's why we ended up having to declare the major incident. They did resolve it. It was our provider that resolved it by the end of the day. Apologise if that sounds a little bit confusing, but that's why we stepped up our senior leadership team, because obviously when the event happened we were hopeful it would have come back up again very quickly and that they would have resolved very quickly. That didn't happen, so we thought, okay, we've got a problem here, and because they were telling us at that point they didn't know what had happened, we didn't know how long then that the system would be down for, so that's why we had to obviously step up our major incident protocols at that stage.
Absolutely sure that there is no sensitive data has been lost?
There's
none.
No indication there's been any data lost. The way that our system works is that whenever the system shuts down, obviously we wouldn't be able to put any more data into the system at that point in time, but it is hosted by the regional system. So the Encompass system is a regional database, and that's where that information would be held. So no
all your hands up. I'm not sure if you want to come in again on some of this, or it's up from earlier.
No, I've just put it up just again to confirm and clarify. I don't want to wander into too many analogies that don't work here, but
It's definitely not working.
It was sure to happen.
Lost him.
We're going to put this down to Wi-Fi rather than anything else.
Been any risk consequent to that where that patient data was lost?
Oh, sorry, we lost you there at the start. So.
Do you know that technology thing? It's wonderful when it works. Sorry, I was just clarifying the extent to which that point about no patient data being lost. It's another layer we're talking about here. It's like understanding the road network or the electricity network or something. It's not, at no point is anything moving around that is patient identifiable, or in that respect, that's ostensibly the thing that was unable to happen. So therefore, there was no likelihood or no possibility of any loss of data of that nature.
I think that's important. I'm happy.
Fair enough. Thank you.
Okay, Danny.
Thank you, Chair. Like the Chair, I'm not very technological minded. So a lot of this, I started nursing 20 plus years ago, and it was all pens and paper. So, you know, the progression into electronic communication forms of documentation and things has been quite profound since then. But just to say, 1,600 appointments demonstrates just how busy the level of activity across the Trust is. You know, that's obviously huge in 2 days. And it wasn't across all services. It says adult community services were unaffected. So why was that?
Well, I just, like, one of the reasons is because they were not directly on a network. They were using mobile internet and so forth, and they were able to access the Encompass system. You know, so a lot of the work that they were able to do was actually able to be maintained. Now there was some impact trying to get maybe access lab results going through the Trust, but generally speaking, they were able to actually do quite a lot of their work anyway. So there was a difference between community and in the hospital. So
They keep it up. Then.
So the community work actually broadly continued. So that was good. So patients who needed that support in the community got that.
One thing I was going to ask you, and I know you'd alluded to running out of pens, and pens and paper is, you know, I remember doing things, and when things go down, that's what people will reach for, you know, ultimately. Are you aware of any issues of Encompass going down regularly, where nurses have to reach for pens and paper on a monthly basis, or?
So I suppose just to clarify, it wasn't Encompass that went down, it was our network. So Encompass is still working for the rest of the region. And there will always be scheduled downtimes in any system. You know, we would at times have to put our system down for maybe an hour at lunchtime or at night time. There have been some regular planned downtimes in terms of the Encompass data centres as well, and usually planned at night time when it's not as busy, and our business continuity arrangements will kick in at that stage. So our staff are used to these things happening in a planned way. They're not used to them obviously happening in this unplanned way for this significant amount of time. But it's not that the system has been, you know, continually glitching for a period of time. There will be times when there'll be downtimes, but they're usually planned.
Your planned downtimes for Encompass, how often and how long are they?
We've had, now Paul might keep me right on this, I think we've had 3 since we went live on the 8th. They usually are about an hour. It's a maximum of 3 hours in the night, but they usually get it down and up again within an hour. It's usually about 3 in the morning.
And when did the Trust go live? The 8th of when?
Sorry, say that.
8th of May. 8th of May. We were one of the last 2 trusts to go live.
Mm-hmm. Those downtimes have gone very well. You know, they've been managed.
This is not a regular occurrence that has to be scheduled. There's no scheduled downtime.
There is scheduled downtime. It's usually done in the small hours, you know, when there's frankly not much happening and with significant advance notice.
Night staff might dispute that.
Well, yes, fair point, yeah. Well, I mean, when you started with paper and pens, I mean, I think I started with quills and vellum. But the difference is the schedule. People know they're coming. They're chosen periods of when there's very low activity. For it to happen at the start of a busy day with every department up and functioning and people driving into the patient car parks, you know, that's why it had such a big impact.
It does occur to me that when everything's done on Encompass now, medicines, observations, notes, blood results, everything. When that goes down, when you can't do anything, so you're reverting to a very, very a Stone Age almost type of pen and paper. So, but this does happen regularly.
Paul's got his hand up. I'll let him in just a second. But to be clear, there are enormous benefits from electronic patient record systems, the small amount of maintenance that's normally required can be easily dealt with in the way that I described. We want to minimise incidents of this type, but we do have to have backup processes. Departments have red books that tell them what to do, etc. It will happen. Last year, I spent most of last year as the interim chief executive of the Royal Free Hospital, one of the big London teaching hospitals. We had a similar kind of incident while I was there. I hope I'm not the Jonah, but in that case it was the firewalls rather than the servers. The firewalls were stopping our systems communicating with each other.
We'll let Paul come in
Could
just to
I
answer.
just clarify, sorry, just one of your points, if that's okay. We do have, Encompass does hold a lot of our information, but we do have separate systems for labs and for our radiology for testing. So those, when we're talking about those planned downtimes in the night of Encompass, the other two systems, we wouldn't put in all the systems down in one go. Those other two systems are still working.
Paul, you wanted to come in on some of this?
Yeah, it was just that word upgrade, because I mean it can be shorthand for a whole number of things. So the very conversation we had about things like potential cyber resilience and making sure that you patch and upgrade your system, well, you do that under through the small hours under the term upgrade. In some circumstances, that upgrade is to bring a new version in because there are developments and enhancements in the product that colleagues want to use in the organisation and delivery of patient care. In some contexts, and a number of colleagues joined us, and I thank you for that, in the Long Gallery on Monday around the promotion of the MyCare app. Well, again, what we were discussing there was a roadmap for increased functionality in the MyCare app. That will require upgrades, but those upgrades will take place at appropriate times, and as Steve outlined at the start, they'll take place in a planned manner, so that again there's no surprises. So that word upgrade is a catch-all of quite a number of undertakings that are all about continuously improving the product in terms of its resilience, its functionality, its use and application for us.
Thank you. Just in terms of learning from this, obviously having more pens will be something that you'll have picked up on. Well done. Is there, have you developed a plan for should this happen again? Because as we say, we live in modern times, we rely almost absolutely on technology now, so having a plan in place for when everything comes down, is that something you're developing?
No, it's something we have. We have a business continuity plan. That was the plan the teams were working to. What we need to do in the light of a real incident like this is say, was the plan good enough? Was it comprehensive? And did we enact it properly? And although it's a slightly flippant point about pens, it's that sort of thing that you can pick up sometimes. So there will be a proper review of our response reported to the board. It may involve changes to the plan itself. It might involve some more training for some departments or provision of more equipment or something. We don't know yet, but we are required to do that review after a major, either a major adverse incident external to the hospital or a business continuity incident where we've lost functioning, as in this case.
Just as a nurse who's been using Encompass, medicine administration is part of it now, which it's good, and there's a lot of benefits for that. Was there any interruption to medicine administration then within the hospital? Did anybody miss doses of anything, or?
Well, what happened is that the staff were able, in most cases, be able to see what the medicine records were, and because it went on for quite a length of time, the staff went back to paper medicine charts to make sure that was recorded correctly. The patients got their medicines.
They all
got them
had to be rewritten, all the medicine charts?
So there was, at one page they were writing up medicine cards to preserve safety.
For every patient?
For the patients in the hospital. So obviously the patients are out patients. They don't know, it's just the ones who are inpatient. So the procedures for that were in place. And then when the system went back up again, then some of that data was put back on the electronic system, the Encompass system, to maintain the record.
Do you know if there's any doses missed or anything like that?
No, we're not aware of that at this stage. No, obviously we look to make sure that hasn't occurred, but we're not aware of anything significant, no.
Hard enough getting a medicine card X rewritten at any point, but I assume you're probably talking.
Staff were very attentive to that. That's the one thing. Like, we have the nurses working with our pharmacists. We had our doctors as well. So all the staff were thinking about that. So that's one of the things that came up, and there were particular discussions about that. So it was well cited in that.
Glad to hear.
Yeah.
And the great thing about this system is when the business continuity devices that are in the hospital, when things go down, it goes down, and you've got all the data that is live up to that point in time. So you do still have electronic access to all the medications, the recent observations, all of that on your PCs that are in the ward, and then it's when you start the manual reporting from that point on, and then you go back and then update the system afterwards for all that information.
Remained up until that point and was accessible by everybody up until that point?
That's what part of our review will look to make sure everybody managed to get access. There are PCs available for everybody. They are there. There's a process to follow to get onto them. But our review in terms of our business continuity and how well it worked will look at Did everybody manage to get on? Were there any problems? It's a bit like couldn't find the pens to make sure everybody knew how to do it. I suppose we're very close to go live with Encompass. It was only on the 8th of May, so this is very soon. Our staff are just getting used to using the system in a live environment. We've now obviously then moved into that business continuity environment very quickly for them. So this is a really rich learning experience for us and for the rest of the region about, well, how well did the training that we gave you work? Did you know what you were supposed to be doing? Could you find the information okay? And we will absolutely be looking at that.
Very interesting to see that.
Yeah. Oh, thank you, Chair. Yeah, I love the root cause analysis. That's a sort of what under God happened here sort of event, but it's good that you're doing it to be able to find out what took place. There's just 2 points. Number one, obviously things like Encompass and Epic and other bits and pieces are, and again I've limited knowledge, but they're like software, and obviously all of the software has to exist on some form of hardware. Has the hardware being kept at pace with the software? So in other words, as more and more people are using more and more parts of the service and everything's going towards an integral online basis, is the underlying hardware able to cope with everything that's there, and has it been upgraded at the same pace alongside the likes of Encompass and other additional services?
Our network infrastructure provider looks after both of those things. So the big hardware, physical things in the data centres are kept upgraded by the same people that are doing the software. Now, they'll be buying parts and from other people, I'm sure, but they are responsible for both. And that contract ensures that those are kept up to date.
That has been upgraded alongside the Encompass.
So that was part of the cost of implementing Encompass. Well, putting it simply, was it required a lot of investment in hardware and new maintenance contracts, etc. Is it entirely sufficient? Actually, we were having a bit of a look at that at the moment because, we're 3 or 4 months in. Has everybody got what they need? Is a good question to ask ourselves at the moment anyway.
That's good, and it's good that you're doing that check to be able to make sure, because if it's out to a third party, somebody on your behalf as the purchaser will need to be keeping an eye to make sure that they are upgrading everything as required, because if it's not up to standard, it will collapse, and then you'll be left picking up the pieces of that. Also then, just do we have absolute assurances and have checks been done? There were ambulance diverts that were on as a result. Has a track been done on all of those patients to make sure that anybody that was diverted didn't suffer a detriment from having to travel further to get the emergency treatment that they needed? Or I know, for example, to the top of your head, if somebody had a stroke and they were waiting a period of time and they were diverted to somewhere else, did that delay by going elsewhere have any impact on anybody, or was at least a check done on all the patients that did have to go elsewhere?
I would just say that the protocols for diversion of ambulances are actually well utilised throughout the trust, and that happens as part of normal service within the ambulance service, and NIAS are very good at diverting ambulances. They're very skilled in that, and they use their call centres to divert the calls appropriately. So if there's any incidents, obviously they will notify us of that and the other trusts, but as far as we're aware, there's not an issue with that, but it is standard protocols were put in place to do the diverts. That's well worn paths. That's done, and happens relatively often within the organisation, because sometimes there's a particular emergency department might be at capacity in any of the trusts, and then the ambulance NIAS service will divert as part of normal protocol to balance the system. We work as a system of hospitals.
It's how precarious the system is, because obviously if an ambulance has to travel an extra 40 minutes because it's on a divert and it's 40 minutes there and 40 minutes back, it's off the road for 80 minutes longer, and then the next 999 call could be impacted by that. But obviously NIAS will keep an eye on that from their perspective to see if there's been any impact as a result of diversions, if it's created any difficulty.
Yes, they do that in conjunction with a regional control centre. The much more common reason for doing it is one hospital's under particular pressure, and actually than this sort of problem, and they have modelling that shows them where to divert to as the next best for travel times. But nonetheless, there will have been some loss of capacity as a consequence of this, but sadly, it's not that unusual at the moment for other reasons.
That's great. Thank you, Chair.
It's just a very quick point on the back of previous question, just around the infrastructure. Are we sure that the infrastructure is fit for purpose, as in the IT system is fit for purpose, or do we need to wait to the outcome of this to see if it's fit for purpose and have the department, Paul, this is probably for you, as our only departmental person here, have the department given any assurances around support for the trust if it's the case that it's not fit for purpose? Because they haven't been very good to Southern Trust in terms of infrastructure across the board in the past, so I'm speaking up for my constituency here, I'm not going to lie.
I think I'm just going to go back to a point Steve made sort of moments ago, Linda, which is the extent to which the specification for deploying the EPIC product, the Encompass program, requires a minimum set of standards to be in place in relation to the digital infrastructure upon which it runs. So those things come hand in hand. So at the stage of turning on Encompass across the respective trusts across the province, the infrastructure will have been upgraded to be appropriate to support that turn on. We know that over time, technology moves on. We know that over time, bits and pieces, laptops run out of steam after 4 or 5 years. We'll always want a longer term view, but here and now, the infrastructure and the functionality of Encompass are working effectively hand in hand.
I suppose I wasn't just talking about Encompass. I mean, that it wasn't Encompass that went down. It was the system. So it was really that specific infrastructure and the system that is in place in the Southern Trust is okay, is fit for purpose, does not need updated.
Yeah, sorry, the reason I was tying them together.
No, I know, I understand.
Is the extent to which you can't run Encompass unless you've got that infrastructure in place to an adequate level in the first instance. It's almost an expectation when you contract with a partner like EPIC that they say to you, we'd love to come and do this job in Northern Ireland, but to ensure that our product works to best effect, you need to get your infrastructure up to this enabling level. And that's what therefore happened hand in hand as the rollout was progressing with the last two trusts at the start of May as detailed.
That'll do for now.
Can I ask a question in terms of the cost that the trusts and the department spends on IT? I mean, is that something that we can quantify? So, like the regular yearly costs of IT for the department and the trusts?
So, I know we're currently undertaking an exercise to respond to that question because that question's been posed this week. I think I don't have an answer to that off the top of my head. I'd almost go back to my first point as well, that it's as critical to pay attention to the people and the process as it is to the technology. But we will, as requested, be attempting to respond to a roll-up number as to what that figure of what that figure represents. I'm obviously a champion for more because that's the nature of what I do with and colleagues in the system. But we will attempt to respond to that question in some level of detail.
I mean, I'm obviously not aware of who else has asked the question. It just came into my head 2 minutes ago, hence I'm asking it. So can we, as the committee, get the information as well as whoever else had asked the question?
Yep, absolutely.
Okay, thank you very much. That has been useful, and I mean we'll definitely hope to hear more whenever you hear more, because it's very important. So it is. So thank you very much for coming for us and taking our questions. Thank you.
Thank you for accommodating me remotely today. Thank you.
Okay, members, any further commentary on that? No?
Obviously, it's something we're going to have to come back to once the review's done, but that's really, I suppose, it in terms of what people can tell us for now.
Okay, moving on then to item number 8, correspondence. So can I just refer members to correspondence, which is on, or to the correspondence on page 3 of our table papers from the Department of Health regarding Healthy Child, Healthy Future event today in Parliament Buildings at 2 p.m. So me and Danny got invites, but obviously the invites were pretty nuggetry at this stage. So I mean, I was going to suggest that we write to the department just whenever they are considering events in this building that are health related, that they try and avoid Thursday afternoon, because it's something that's, I mean, that's a very important event today, and nobody from the health committee can attend. So I think it's important to make that I'm aware of that. Everybody happy with that? Okay. Also, just refer members to response from the department on page 175 regarding hospital transformation. I mean, when I read it, a lot of it's in relation to GP and primary care facility. So I was going to suggest that we forward that to the Royal College of GPs in the North and also the BMA, just because, you know, they might have some commentary on it, if people are content with that.
Yeah.
Chair, might have a comment to make on that one.
Okay, go ahead.
So obviously Minister Tetchy obviously got out of the bed the wrong day, the wrong side that morning to give that reply, but I think he uses terms like offensive and inappropriate. Well, in terms of offensive is the Ulster-Unionist minister from 2008 that closed a ward in the Down Hospital before it even opened. And also what has been inappropriate is that we've had a misdesignation of our emergency department for the last 11 years. I know that there have been a number of the Trust chief executives have stood in public and actually said that it was a wonderful attribute that we had 2 level 2 hospitals units within the South Eastern Trust, that was something they were very proud of, and that's been said publicly. And then it transpires that after 10 years we haven't even got the designation right. So the response that is in there doesn't tell us why we got it wrong, who got the diagnosis wrong, and why have we been told that. And where it's really important is we have 5 trusts in Northern Ireland. 4 of the trusts have 2 level 1 emergency departments, and 1 trust has got a level 1, and we were sold 2 level 2s on the basis of them being somewhat together the equivalent of a level 1, and it was being split to provide the service. But if that's not the case, why is it that the South Eastern Trust only has 1 level 1? It's one of the biggest trusts. I think it's the 3rd out of the 5 trusts, but we have only got 1 level 1 emergency department, which sits about 400 yards from the border of the Belfast Trust and serves a massive population in the Belfast area. And we are left with just 1. And whenever we're sold that pop, as it were, on the basis that we had 2 level 2s, and it now works out that they're not level 2s, that's a major problem if you get the designation of your hospitals wrong. And how many reviews have been carried out in the last 10 years where the review document will say, here's what you've got in your area, that includes saying you've got 2 level 2s whenever actually we had 2 level 1s. I think that's a major gaffe. And I think that the remarks from the Minister are overly defensive, but I think that they are defending the fact that they're covering up that there was quite a major gaffe that has been made there over the last 10 years. And I think that we should ask for more explanation on that. And we should try and keep it focused on the actual issue, which is why are the people of the southeastern area only allowed to have 1 level 1 emergency-based unit while everybody else in Northern Ireland gets 2.
So are members content that we write to the Minister in relation to that?
Fair enough, yeah.
Okay. Happy enough? Mm-hmm. Okay. Just other parts of the correspondence. So can I refer members to departments from our response from the department, page 185. It's regarding correspondence received from the breast cancer. Now, the members have any comments on that? Not. I'm going to suggest that we forward the department's response to breast cancer now. Okay. List the rest of the correspondence list is there. We had correspondence from Alma White of Caleb's Cause, just in relation to some requests. Keith, I'm going to ask you to maybe comment on that.
Certainly, Chair. We got a request in from Caleb's Cause in relation to requesting the committee undertake an inquiry into the issue of post-19. As you'll have seen from the committee's strategic priorities paper, this year is very legislation heavy, and the committee has taken the decision to focus on a number of key priority areas. One of those key priority areas is in relation to respite care, which you'll appreciate is quite closely linked to this issue, and especially to children with complex needs. So I think there is something that the committee could look at in relation to children with complex needs, and seeing how we could take that forward as a committee priority, alongside the respite care and what Caleb's cause is raising as well.
Glenda?
Yeah, I think you've actually just addressed it, Keith. It's the widen the respite care bit out, because it is all connected. Everything to do with young people with complex needs is all connected, and every bit of it needs to be right. And I think one of the things that you'll hear from the families is about a plan. You know, so it's a plan, and it has to be about every part of their care and their needs and their requirements just to live a normal, healthy life. So it is about the respite, it is about what, you know, whether it's day opportunities or whatever, you know, is going to be provided. And it all has to be supported by health. So I think, yes, I think we should maybe widen out the respite care and include, that doesn't mean we lose respite in the middle of it, but I do think that we need to actually include all of the other elements, because it's all interlinked. You can't separate these things out, and a plan is actually what the families want, a care plan.
Can I ask Keith, you might be able to clarify this, and this is not in any way dismissing what Alma is looking for. I think we should be very supportive of everything she's doing, but was there inquiry on post-19 provision already back some years ago in this assembly?
I will check that out. There is something in it would have been a number of years ago, so it is, but I can have a check and forward that information through to
Again, it brings me back to the comment that I made last week, that if that is so, and the department has been aware of the cliff edge for all these years, why has nothing ever been done? Why has it took a campaign from Alma White to start nudging this forward?
Yeah. Well, I mean, I think Alma has written to us, so I mean, respite is a priority for the committee, so we're going to maybe just extend it a wee bit. Danny, go ahead.
Just to pick up on what both of you are saying, absolutely, totally agree. This is a multi-departmental issue, and it touches most other departments, as we've seen in our economy, have already made announcements about their responsibilities on it. It touches a lot of health, and particularly I think it does fit in with the short breaks and residential. But if we could have a particular focus on transition times and that post-19 transition in particular, I think that would be something that would be beneficial.
Colin?
Yeah, it's just followed, to me it's one of those issues that has so many avenues that actually you could get lost in trying to do anything, and I think we should try and keep it as specific as possible, but with that specific analysis being on what maybe the families are maybe even asking them what is the thing that they need most, because we're not going to be able to change the whole system. We can't influence what other departments and other other ministers and other areas do, but if we can find some of those things that are very specific, get tore right down into it, and then come up with something that tries to help the families.
Okay, everybody.
Yep,
go ahead.
Just say we've been having a discussion with the independent autism reviewer about maybe looking at doing an event to bring some of those families together, the much wider than respite care, but those families with complex needs. So that's certainly something that we could focus that meeting or event on, is seeing what's important to them.
Okay. Fair enough. Now, moving on, item number 9, forward work programme. So can I refer everybody to the draft forward work programme, page 324. So can, Keith, you want to come on this again?
Yeah, just to say, following the discussions last week in relation to the inquiry, we've got a new date for the inquiry launch. So the date of launch is looking likely to be Tuesday the 2nd of December. So it is, so that takes into account some of the times that members aren't available. Also, towards the end of November, there's a big UK hospice conference. So it is that a lot of hospices are already attending as well. So it'll be Tuesday the 2nd of December. The committee team at the minute are working on the report again. Now I've got a wee bit more time, taking into account some of what members have said. So we're redrafting it at the minute, so it is, so we'll have that for members in a couple of weeks to look at. But again, if members have any comments or any particular issues, if you can let me know in the meantime, we can make sure it's reflected in the new draft of the report.
Okay.
Thank you.
Ian Groella, any other business?
Yep.
Keith, could I just ask, in terms of dates for members, when do you want to have sign off?
Ideally, I would like to bring back a revised report probably in 2 weeks' time. So if I could have comments from, or general comments from members about what things you maybe have looked at and seen you want included, probably by 2 weeks' time, 2nd, 9th, by maybe the 7th of October. Tuesday the 7th of October. And again, please feel free to get in touch. I'm happy to come and have a chat with you, sit down and go through it. But it would just be good to have an idea of what members want, if there's anything else you want included in there, before we get the final sort of draft stuff back to you.
Okay. Okay, members, last thing then is date, time, place of next meeting. So next Thursday, 2nd of October, in Shaw, room 29. Meeting adjourned.
Committee Room 29, Sound.